It's a nice way to start the day when you have a beautiful lady starting us off, isn't it? Welcome. This way, this way. Okay. I can use the mic. Morning, everyone. So I work in Kiambu. This narrative review was a fulfillment of my Master's of Science in Endocrinology. So I did a narrative review on testosterone deficiency in males with non-alcoholic fatty liver disease. For the purposes of this presentation, I'm going to call it NAFLD. However, the name has since changed to metabolic associated fatty liver disease. So just a bit of background. So the prevalence of NFLD has been on the increase globally. So initially how it starts, you have a healthy liver with less than 5% of the hepatocytes having steatosis. And then it progresses to non-alcoholic fatty liver disease, in which you have more than 5% of hepatocytes with steatosis and also a bit of mild inflammation. Then you progress to NASH, non-alcoholic steatohepatitis, where now you have steatosis, inflammation, and ballooning of the cells, and then progression to cirrhosis. However, before you progress to cirrhosis, this process is reversible. So at cirrhosis, you have presence of fibrosis, and there may also still be features of inflammation before the person develops hepatocellular carcinoma. NFLD is a pro-inflammatory state associated with lipotoxicity, insulin resistance, oxidative stress, and increased coagulation factors and inflammatory cytokines. And these play a role in the various systemic abnormalities that you find in NFLD. So the most common cause of NFLD actually is cardiovascular disease, which is followed by extrahepatic malignancies and then liver-related causes. So the complications of NFLD are many, and I've highlighted them over there. If you notice, hypogonadism, PCOS is there, type 2 diabetes, obesity, and all the way up to hypothyroidism and growth hormone deficiency. Lifestyle management is the cornerstone of therapy, and a link has been found between NAFLD and testosterone deficiency in males. And it has been postulated that if you replace the deficient testosterone, then you may actually retard the development or even the progression of NAFLD. So this diagram just shows the link between testosterone deficiency and NAFLD. So the initial injury is thought to be an increase in the adipocyte mass and numbers, which increases your free fatty acids, which are then deposited in the liver. You may also, the increased adipocytes may also increase aromatase, which aromatizes your testosterone to estradiol. Can also increase the adipokines and leptin, which now have an effect on the hypothalamus, and therefore you have a decrease in the gonadotropin releasing hormone and a decrease in the luteinizing hormone, which now affects your testosterone levels. The decreased testosterone by itself can also increase myocyte differentiation and increase insulin resistance and increase your adipokines such as tumor necrosis factor alpha and interleukin-6 as well as leptin. And this also now propagates the development of NAFLD. Testosterone deficiency also by itself increases the activity of lipoprotein lipase, which increases your triglycerides, which are then deposited on the liver. The adipocytes also by themselves will stimulate aromatase, which now still decreases your testosterone. So my objective was to evaluate the evidence regarding the association between testosterone deficiency in adult males and the development and or progression of NAFLD, and also to evaluate the evidence regarding whether testosterone replacement therapy, even when given for other indications in men who had hypogonadism, conferred additional clinical benefits in males with NAFLD. So in my methodology, I comprehensively went through the various databases which are outlined there, and I used mesh terms and synonyms to retrieve articles. I retrieved articles published between the year 2000 to April 2023, which looked at NAFLD and testosterone deficiency, as well as testosterone replacement therapy in NAFLD. I excluded the studies shown there. However, I still included abstracts because of the paucity of studies, so long as they had adequate information for retrieval. So in my first objective, which was looking at the association between NAFLD and testosterone deficiency, I retrieved 22 studies. Most of them were from Asia, the rest were from US and Europe. There were no studies in Africa, unfortunately. So diagnosis of NAFLD varied. Some used ultrasound, CT scan, MRI, and all the other diagnostic tests listed there. And a majority of the studies found that there was an association between NAFLD and testosterone deficiency. 4 studies showed no association, 1 showed mixed results, in the sense that this study showed that testosterone deficiency was associated with inflammation but not with fibrosis, and this was postulated to be because of decreased androgens in patients with fibrosis, and therefore they still found elevated testosterone in these patients. My limitations is that there were no RCTs. There are few studies which are adjusted for confounders like diabetes and insulin resistance. Then they use various modalities to diagnose NAFLD. And then the cutoffs for testosterone widely varied between the studies, and they used various assays. Only 5 studies used the gold standard, which is liquid chromatography mass spectrometry. So in my second objective, which was to look at the effects of testosterone replacement therapy in NAFLD, I had to include animal studies, again because of the paucity of studies in this, especially in this second objective. So I found 6 animal and 10 human studies. All the animal studies found beneficial effects of testosterone replacement therapy on NAFLD, and 7 out of 10 of the human studies had beneficial effects. So what are the postulated mechanisms by which NAFLD was ameliorated by testosterone replacement therapy? It was thought to be because of an increase in the lean mass and a reduction in the fat mass. And testosterone replacement therapy has also been postulated to modulate key enzymes involved in lipid and glucose metabolism. So what are my limitations? So the animal studies are very small sample sizes. They were using as few as 12 rats. However, the good thing with these studies is that they were randomizing the rats. And then the findings, of course, cannot be extrapolated to human beings. For the human studies, there were absolutely no RCTs, and very few adjusted for confounders like diabetes, insulin resistance, and then they've used various diagnostic methods ranging from ultrasound, and ultrasound cannot detect liver fat less than 30%. Some used MRI, some used markers of liver fibrosis or inflammation. And then there were various formulations used for testosterone replacement. Some used buccal tablets, some used the topical testosterone, IM testosterone, and then the duration of testosterone replacement therapy really varied from as less as 6 months to as long as 8 years. And then again, also because the human studies were in certain populations in the Western world, we cannot generalize to the rest of the human population. So in conclusion, research has shown a strong association between NAFLD and testosterone deficiency, and this is notwithstanding the paucity of large-scale studies. The ideal pharmacological agent, as at the time I was doing my thesis, was elusive. Right now we know that FDA approved, in March, approved resmetirom, which is a T3 mimetic. However, as of this time, only lifestyle management remained the cornerstone of therapy, and other therapies like vitamin E, as well as use of statins, have not been approved by FDA. And then testosterone replacement therapy in hypogonadal males with NFLD may be beneficial for these patients. And in my recommendations is that guidelines globally should consider screening for testosterone deficiency in people with NAFLD and vice versa. And then there's a clear need for more robust and well-designed trials with larger sample sizes and longer duration of testosterone replacement therapy, but at a dose that minimizes the side effects of testosterone replacement therapy, like acne, depression, aggression, and gynecomastia, which I'll be talking about tomorrow. So these are my references. And thank you.
It's interesting. It's good to have thought-provoking notions early in the morning on a Friday. So there'll be no Q&A. Remember, we are showcasing just the thesis that they've done. Next in line is Dr. Ann Wairagu, our village doctor, consultant physician endocrinologist extraordinaire from Gatundu Level 5 Hospital. And the interesting thing about her is she keeps us sober. You know, we get all fancy, then she says, but on the ground, vitu ni different. Karibu, daktari.
Thank you, Rosie. I appreciate it. Good morning, everybody. I was in the same class with Dr. Irene. We come from the Kiambu County, county number 22. And thank you for waking up early this morning. I know some people is like, oh, abstract, why should I come? But no, I understand. So my topic, I decided to focus on metformin, associated diabetes, B12 deficiency. That was my topic. In patients with type 2 diabetes in sub-Saharan Africa, it is a narrative review, so we didn't have actual testing of this B12 deficiency in the patient. So just picking literature and putting the evidence from that literature together. I don't have any conflict of interest. This is my outline. I'll do a bit of introduction, the background of my study, then objectives, methodology, results, and recommendations. Part of the introduction is that type 2 diabetes is quite heavy in sub-Saharan Africa, and metformin is an oral glucose-lowering agent from the biguanide group, and is a key drug in the management of type 2 diabetes, since because of its safety profile, it's cheap and it's quite available in a low resource setup, and its mechanism of action is quite good, and in bringing the HbA1c on the lower side. So metformin has been associated with B12 deficiency. However, we have limited research which existing regarding metformin-associated B12 deficiency in sub-Saharan Africa. And this is what I said to find out, is it really there or it was just a story? So type 2 diabetes, it affects around 5% of the population. This is by the IDF 2021. And there's a rapid rise due to the medical transition because of the issues about the kind of food you're eating, the transportation that has improved. And type 2 affects 90% of the cases of diabetes, is the highest. And overall, the cost of diabetes is quite on the higher side, and you can see it costs 1.2% of the GDP. Metformin use in sub-Saharan Africa is a first-line therapy because of so many benefits that it has, as I said. It is low cost, good safety profile. It is weight neutral, and has proven efficacy and accessibility, making it a very fast, good choice in sub-Saharan Africa. A bit of pharmacology of metformin is a biguanide, is an oral tablet. It's only biguanide available since the others were withdrawn. It has different mechanism of action. At cellular level, it activates the adenosine monophosphate kinase. In the liver, there's suppression of the gluconeogenesis. As the skeletal, it promotes the uptake of glucose by the skeletal muscles. Then overall, there's increasing insulin sensitivity and also inhibition of the mitochondrial respiratory chain complex 1. What about the B12 as a vitamin? It's a water soluble. It contains mineral cobalt, and hence it's referred as cobalamin. It's only found in meat and other animal products like dairy. So for those who are vegetarian, they may have a deficiency of the same. It's a cofactor. It's an essential cofactor in the DNA synthesis, in the enzymes that are involved in the DNA synthesis, the methionine synthesis and methanyl CoA mutase. Is a prerequisite for optimal hemopoietic and neurological functions. The deficiency is as a result from three main factors. One, there's either autoimmune process, you know about the pernicious anemia. Then inadequate dietary intake, which is common in the sub-Saharan Africa. And the third mechanism is because of malabsorption, and this is a mechanism by which metformin is thought to cause the B12 deficiency. Vitamin B12 deficiency is common, the commonest cause of megaloblastic anemia. As you know, the other causes, you have the folic acid deficiency. And the major factor is the dietary. We know majority of our people, we eat the cereals, the warus. My colleague here, Irene, she loves the warus. Then you also have the maize, the githeri and stuff. So our foods lack on the meat and other products. Inadequate intake is quite common because most people, there's a study we showed in Kenya and Ethiopia, they showed most people who have dairy farming, they prefer to export than to eat. So most of the dairy farming is for export. Other factors that are being associated with the B12 deficiency is because of the older age. Type 2 diabetes by itself is a risk factor for B12 deficiency. Fish tapeworms and bacterial overgrowth, which is common in this area. This is a pathophysiology. Long-term use of long-term use of metformin reduces the secretion, increase the motility. There's an effect in the liver. There's an effect in the malabsorption. So all these effects cause the B12 deficiency. And now there will be an impaired methionine. Then at the end of the result, there will be the malabsorption and the neurological. You find the neurological symptoms and the other symptoms I'm going to say. So most they present with subclinical cobalamin deficiency is the commonest presentation. It takes like 3 to 5 years to manifest the deficiency. The clinical manifestation are divided in neurological, psychiatric, and hematological effects. The guidelines, there's lack of guidelines, and the screening test is not clear. Do you do the serum B12 assays or the other tests that you can see? And the other challenge is the availability of these tests. So my research did bring us to my research question: what's the evidence for and risk factor for metformin-associated B12 deficiency in adults with type 2 diabetes? And what are the available clinical guidelines on the diabetes management and the recommendation of monitoring B12 status and treatment of vitamin B12 deficiency arising from metformin therapy? And these are my study objectives: to see the prevalence, to assess the risk factors, and provide an overview of the guidelines available. I did a literature research, and these are the databases which I searched: the PubMed, Medline, and Scopus, Ajol. Then the data was based on the studies done for over 20 years. Great researchers was also searched, and clinical guidelines was also searched. The eligibility was studies that were concerning the topic of the day. And those who was excluded were those one who had insufficient data, and then review articles, and those one who were non-English articles or the guidelines. So data extraction was extracted, year of publication, that's characteristic of the studies, and the quality was assessed using that tool, because we got the SEMBAS tool, 2014. For the guidelines, we picked the relevant guidelines which had shown about screening and monitoring of B12 status. In the yield, there was 24 articles. By the end of the day, I was able to analyze data from 7 articles. There was a shortage of articles concerning this topic. For the guidelines, I was able to pick 22 guidelines out of the 18 African countries, because some of the countries are non-English, so they were excluded from my study. And I had a total population of 1,000. Around 1,000, and the prevalence was shown to range between 5 to 41%, quite a varying range. And the risk factors I found: high metformin dose, long duration of metformin therapy, long duration of diabetes, advanced age, high BMI, a better control of glycemic control because of they required a higher dose of metformin, and black ethnicity. What about the guidelines? I found there were quite few in South Africa. None were evidence-based, and none recommended routine screening of B12 deficiency in metformin-treated type 2 diabetes. Selective screening was suggested in 3 guidelines from Namibia, Kenya, and South Africa. And the treatment guidelines were unclear in terms of what is the dosing schedule and the duration of therapy. None of them was very clear on that. So my study strength is that I complied to the PRISMA guidelines, which in selecting the articles to use. I also, the articles were also established, the quality was subscribed with that tool I've mentioned, SEMBAS critical tool. And this review has brought us to a clear understanding of the magnitude of predisposing factors for metformin-associated B12 deficiency, and it also has brought to light that we lack guidelines in sub-Saharan Africa. My limitation is like only 7 studies were available. Majority were cross-sectional, 6 of them were cross-sectional, only 1 was case control. I didn't have any randomized clinical trial that was available in this region. And this was a major challenge because, as you know, RCT carry more weight than the cross-sectional studies. And it was hard to generalize this because the different studies used different methodology and different cutoff for the B12 levels. In conclusion, say metformin-associated B12 deficiencies in can concern type 2 diabetes management in sub-Saharan Africa. Several risk factors were identified. There's lack of clear guidelines on the screening, diagnosis, and treatment of metformin-associated B12 deficiency. And there's a need to create awareness amongst clinicians on the existence of this condition. Then selective screening for this condition should be carried out in high-risk population. Future studies, RCTs, is what we need to do so that you can have the hard evidence that there's association between the two. Remember, there's other confounding factors. And also we need to, so that we can be able to determine the optimal screening strategies and management approaches for metformin-associated B12 deficiency. Thank you.
Hey, Bana, you're too lethargic. Come on, guys. This is something pertinent. Can you tell me honestly if there are any patients here who are not on metformin? So right, I think this is very relevant. We really want to thank the village doctor. Even if she's in the village, she's doing research, so there's no excuse, isn't there? So next in line is Dr. Florence Kelly. What you don't know is she's the third of the Mushadha sisters. So those ladies are powerful. They do research together, they work together, and honestly, they dress excellently. And she's going to take us through her. She works at University of Nairobi. She's a consultant physician endocrinologist. She's also an executive committee member for Kenya Diabetes Study Group and the treasurer for the National Office for KP. Karibu, Daktari.
Thank you. Good morning. I hope you are all awake. My study is kind of, maybe complicated, but I'm sure you see these patients. So my study title was about PCOS, the therapeutic effects of glucagon-like peptide 1 receptor agonist in adults, in adult overweight and obese women with polycystic ovary syndrome. And this was a narrative review. Remember, please bring forward the knowledge that you received yesterday about GLP-1s, because it will form part of your part of my presentation. So this review was done for the award of a master's degree in science and in diabetes at the University of South Wales. So in the pathogenesis of PCOS, we have genetic, epigenetic changes, post-receptor binding events, obesity, inflammation, environmental factors, and dietary factors and mood interacting. And then we have a situation whereby we have insulin resistance and hyperinsulinemia. And now, this interacts with various factors. We have changes in the brain, in the hypothalamus and pituitary, and the adrenals, the ovary, and the uterus. And because of the insulin resistance, we have reduced glucose uptake and lipid accumulation, reduced lipid decomposition, reduced insulin signaling in the muscles, and the end result is a situation whereby you have hyperglycemia and an androgen overload. So you find that in patients with PCOS, you have ovulatory metabolic dysfunction, excess adiposity, and androgens, and those are mainly the characteristics that you find in patients with PCOS. There are 4 PCOS phenotypes, which I'm not going to dwell on. So my study objectives, because of that background that you have seen there, was to evaluate the effects of GLP-1 receptor agonists on insulin resistance, glucose metabolism, anthropometric, which was weight and waist circumference, lipids, and androgens in women with excess weight, and PCOS. So keywords were used and medical subheadings were used to retrieve scientific articles that were published between 2012 and 2022. So these articles were retrieved from PubMed, MBES, EBSCO, Cochrane Library, and Medline. And my inclusion criteria were all RCTs that were conducted in participants that were more than 18 years with PCOS and excess weight and were on GLP-1 receptor agonists. What was my exclusion criteria? all duplicate articles, literature, and systematic reviews, meta-analysis, observational studies, and studies in non-English language. The quality of the RCTs was assessed using the Critical Appraisal Skills Program assessment tool. And the results? Insulin resistance, 2-hour postprandial glucose levels decreased with liraglutide, exenatide, semaglutide, and dulaglutide. There was also weight loss was most marked with semaglutide, dulaglutide, and versus liraglutide and exenatide. Semaglutide and dulaglutide led to a 7% weight loss from baseline weight, while exenatide and liraglutide led to a 5% weight loss from the baseline weight. There were also other changes in the androgen levels, whereby we had the sex hormone binding globulin, the total testosterone levels getting increased. The free androgen and DS levels were also reduced with all the GLP-1 receptor agonists. All the GLP-1 receptor agonists, that is the 4 of them, except liraglutide, also reduced the total LDL, triglyceride, and increased HDL. And you can see this was a very positive effect. What were my study limitations and cost effectiveness of GLP-1s? The RCTs, the randomized controlled trials were conducted in women of non-African descent. So if we conducted this study, we are likely to find maybe slightly different or better findings in our setup, and this calls for further research in our setup. And then, as you all learned yesterday, GLP-1 receptor agonists cause increased gastrointestinal disturbance. You remember yesterday you were told that never start them during the week or in people who have got white-collar jobs. So there's that effect, and they're expensive. The conclusion, GLP-1 receptor agonists reduced blood glucose and insulin resistance in obese and overweight women with PCOS. Semaglutide and dulaglutide caused more weight loss compared to exenatide and liraglutide. And then hyperandrogenemia and dyslipidemia ameliorated with all the GLP-1 receptor agonists. What is the recommendation in regards to this study? GLP-1 receptor agonists are potential add-on therapy in managing insulin resistance, hyperglycemia, excess weight, hyperandrogenemia, and dyslipidemia in adult women with PCOS. And those are my references.
You see, at Kdsg, we keep time, and then we do such excellent work. We're doing excellent work. We're actually changing. You know, before it's always been metformin for PCOS, myoinositol, but now there's hope for all these women suffering with PCOS, isn't it? And now to cap it off from the Kdsg thesis session is Dr. Betty Shiruli. Elegant, quiet, she's a consultant physician diabetologist from Vihiga Sub-County Referral Hospital. She's amazing, currently doing also her endocrinology, and she's going to take us through her MA thesis that she did as she was doing her diabetology. Karibu Daktari.
Morning, everyone. You're well? Okay, so I've already been introduced. The study that I'm going to present was a narrative review that I did as part of fulfillment for my master's in diabetes with University of South Wales. Yes, so that was the topic, assessing the burden of peripheral arterial disease in African individuals with diabetes. And the aim of this was just to take a peek and just be able to tell the picture of what's going on. I guess it's a topic of interest. Remember the first day when we were looking at diabetic foot disease, this forms a component of that and the risk factors for that. So and I have no conflict of interest to declare, but I acknowledge the sponsorship to attend this conference. So of course, I think yesterday we discussed a lot about how diabetes comes along with atherosclerotic cardiovascular disease, and that we agreed that atherosclerotic cardiovascular disease is the #1 cause of mortality in our patients with type 2 diabetes globally. And of course, when you talk of this, we are talking of coronary artery disease. These are the big forms: the coronary artery disease, the cerebrovascular disease, and peripheral arterial disease. So peripheral arterial disease specifically correlates with the presence of other forms. So we are saying that if a patient has peripheral arterial disease, they are more likely to have an MI, to have stroke, they are more likely to have other forms of cardiovascular disease. And the other big factor with peripheral arterial disease is the association with diabetic foot disease. And of course, associated limb amputations. So one of the issues, of course, as we look at atherosclerotic cardiovascular disease, the mechanisms are quite profound. I think that was extensively discussed yesterday. And we know that diabetes is an inflammatory state. We have formation of a lot of inflammatory products, cytokines, CRP, which trigger endothelial injury and facilitate deposition of LDL, and we start having atheroma formation. Similarly, the hyperglycemia that we have in our patients with the formation of the advanced glycation factors also cause some injury to our endothelium, and we have, of course, accelerated atherosclerosis. So we have all those mechanisms, and of course, an additional factor is that our patients with diabetes have other traditional cardiovascular diseases, yeah? They have rather traditional cardiovascular risk factors. They have hypertension, they have dyslipidemia, and so we have all this milieu in a patient, and we know that they are more likely to have atherosclerotic cardiovascular disease. Now, issues around also peripheral arterial disease in Africa is that I'm sure we've seen that we have deficiency in medical and surgical management of peripheral arterial disease in Africa. It's interesting, a study that was done 10 years ago found that, in 2014, found that the ratio of cardiothoracic surgeons to the population was 1 cardiothoracic surgeon for 3.3 million African citizens. So of course that tells you we are deficient in managing, and therefore we need to identify early and put in the interventions that we can so that we can improve the outcomes of our patients. So my study objective was basically, this was a prevalence study. That was the main issue, was to just assess and look at the picture of what the prevalence of peripheral arterial disease is in African persons living with diabetes. And the other objective was also just to document any associations that was found in studies on the occurrence of peripheral arterial disease in this population. Allow me to call it PAD in short, just for this presentation. So of course, in the methodology, we looked at we looked at different databases: PubMed, Google Scholar, Cochrane, Embase, Science Direct, and African Journals Online. And on discussion with my supervisors, we chose to look at quite an expansive period of time, around 40 years, from 1983 to 2023. And this was because we realized there was paucity of studies in this area in Africa. So we just wanted to look at the big picture and take a snapshot of what was going on. So inclusion criteria, we were looking at studies in African populations living with type 2 diabetes. Those kind of studies, peer-reviewed, original articles, observational, cross-sectional cohort, systematic review and analysis. And the exclusion criteria, we were avoiding any study that was looking specifically at patients with type 1 diabetes. Similarly, we were going to avoid any study that picked a subpopulation of people with type 2 diabetes. For instance, there were studies that looked at patients who had diabetic foot disease specifically. So we eliminated that because we wanted a general picture of what is going on in type 2 diabetes. So we looked at the study. We were able to find 53 studies that fulfill the criteria to be included in this narrative review. And a majority of the studies were done in Western Africa. Big up to our colleagues there. 11 of these were actually in Nigeria. And it just helped me see how we need to do more in this country, in our region. And Eastern Africa, we had 17 studies. One was done in Kenya, and this was actually done by a colleague in 2009, Dr. Mugambi Turibi, I hope I've said it correctly. When he was a registrar in Kenyatta, he was looking at actually peripheral arterial disease in patients with type 2 diabetes at the diabetic clinics. And we look at that as we go along. Then Northern Africa contributed 9 studies, Central Africa 2, South Africa 1. So of course we had eliminated some studies. Some studies in South Africa were eliminated because they had almost 50% of the patients having origins that were not African. So we eliminated those studies because the aim was to just look at African individuals. Then one study actually was done in 5 countries in Africa, East Africa, Western Africa, and Central Africa. And then majority of these studies were actually hospital-based, 50 of them. Yeah. So if we look at the characteristics of the study populations, so the mean or median ages ranged between 41 to 63 years. I guess that is a picture of what we see here in our clinics. Then the proportion of females, majority of the studies had more than 50% being female. I don't know whether we have studies in Kenya about what proportion of our diabetes patients living with diabetes are male versus female. Then mean duration of diabetes ranged between 1 year to 12.9 years. And then an exception to this, one study was a study done in Uganda that actually looked at newly diagnosed patients with newly diagnosed diabetes, those who had been diagnosed with diabetes in just the previous 3 months. It will be interesting to see what they found. So the overall prevalence was actually between 1.7% to 62.3% prevalence of peripheral arterial disease in our patients with diabetes in Africa. So of significance was this study in the 1.7% was done in Zambia. You can see it was one of the earliest studies. And in this study, one of the things that was there was that it was actually used history, history of intermittent claudication. So of course the sensitivity of that mode of assessing for PD was low. And then of significance is this study that was done in Benin, used arterial Doppler ultrasound done by a radiologist. So the sensitivity was pretty high, but you can imagine 62 points, that is like two-thirds of patients having peripheral arterial disease. So of course, yes, so this was the different modalities. This affected the outcome of the narrative review, that different studies actually use different modalities of assessing for peripheral arterial disease. But majority actually used the ankle brachial index, where they used the Doppler device. And these 33 studies found a prevalence ranging between 10.8% to 52.5%. It's very cold here. I don't know whether the temperature can improve. Yeah. And then the ones that were done using the arterial Doppler ultrasound, there were just 3 studies. One was actually done in Ethiopia, another one in Benin, and another one in Cameroon. And the 2 done in Ethiopia and in Benin, in Cameroon, found prevalence of about 30%, using arterial Doppler ultrasound done by a radiologist. And the one that was done in Benin is the one I talked about, 62.3%. So of course you see that these 2 modalities gave the highest prevalences. Then when it was done by history, you can see it was between 1.7 to 4.4%. Physical exam, that is for absent or reduced pedal pulses, between 2 to 10.7%. So we know that the sensitivity of using the physical exam, that is specifically the absent or reduced pulses, is about 20%. Then by combination of history and physical exam, the findings range between 3.4 to 36.8% of the patients having type 2 diabetes, having peripheral arterial disease. So it's just a reminder of the gadget. I don't know how many of our hospitals have this gadget. The ultrasound device that can be, and the sphygmomanometer, for measuring, just a reminder of what that looks like. And we know that the ankle brachial index is basically a ratio of the systolic pressure in the brachial artery, the ankle to the one in the brachial artery. Yeah? So when you looked at peripheral arterial disease in the different Africa regions, so we have the Western.
Your Excellency.
Okay, the metastasis. Yes, so we had, looking at the different regions, we had the highest rates in Western Africa region, that is 10.8 to 52%, 52.5%. And as you can see in the column on the mean to median ages, the mean median ages were actually fairly fairly comparable. In the Northern Africa, we had prevalence between 11 to 47%, Eastern 11 to 39%, Central 18 to 37.5%. The South Africa was not included because that study did not involve the ankle brachial index. So in terms of symptomatology, it was important just to note that majority of the patients were actually asymptomatic. If you look at the various studies, those are the prevalences of PAD, between 68.5% to 80% were actually asymptomatic, just indicating that we need to really consider having more objective assessment of peripheral arterial disease. The associations with PAD was duration of diabetes in 9 studies, age, which is we expect, poor glycemic control, being overweight or obese, hypertension, and dyslipidemia. When we compared with other studies in other parts of Africa, we didn't have very good studies in many parts of the world, but you can see prevalences ranging between 3.2 to 36% in Korea, India, China, and with ages that are comparable to ours. So in conclusion, we say that what this study found that was we have a pretty high prevalence of peripheral arterial disease among these patients, and therefore this denotes a very high cardiovascular disease burden that we need to think about. And of course, this also denotes a pretty high risk of having diabetic foot disease, and therefore we need, and the associations are those ones, and therefore we need to assess, probably establish, ask ourselves what would it cost to have these gadgets in our facilities, even one in just a county referral facility, because that would help us initiate medical management and ultimately prevent limb loss and improve outcomes in our patients. Thank you.
So there'll be no question and answer for this particular session. If you want to take some time, and if you came in late, actually the posters are right outside to the right of this room. Please take your time to go through even various abstracts that will be presented later, and even the work. The doctors are available for any questions. Now we're switching things around, isn't it? And I'll hand over to the Prof. Kunyiha, but shortly. Yes, and we're going to switch gears a little bit and see what has the year been like, 2023. You know, sometimes we forget as consultants, we know what's going on, but it's good to actually give you a flashback of what 2023 is and how it has moved over to 2024. So I have the distinct pleasure of inviting our chair, Professor Nancy Kunyiha, who is also the CEO and founder of Uzwena Health and keeps this running, this boat of Kdsg. You see how it's a well-oiled machine? It's thanks to this wonderful lady. Karibu Daktari.
Thank you. Good morning, everybody. It's a pleasure to be able to give this flashback. I will do it with two colleagues, Dr. Gaman and Dr. Rilwan, and we're going to try in about 50 minutes to summarize what we feel were the highlights of 2023 in as far as studies, AI, and the application of artificial intelligence. So our disclaimer is that any products shown here are for educational purposes. This is not a sponsored talk, and they're not endorsing any particular products. And our choice of studies and content does not represent the entirety of 2023. So last year, one of the big highlights was obesity. So that was one of the big messages, and I'm going to try and summarize this because this is heavy kind of science and very many studies we've put together. And there were two major large groups of medication that were used, and it's good that we had the background of the GLP and GIP discussed yesterday. And the SURPASS trials looked at populations that had diabetes and obesity, and one of the trials actually looked at individuals who had cardiovascular disease. So in a nutshell, the study designs were double-blind, so they were good studies, they were randomized, they were placebo-controlled, and they were phase 3 trials. So those look at safety, they look at efficacy, and they look at tolerability of certain medications. These were multi-center, so they were done in different continents, not just one particular country, And they had patients there for over 19,000 individuals in these studies, and were done between 2019 and 2023. The medication that was looked at was tirzepatide, and the patient population were type 2 diabetes. They were adults over 18 years, and look at those BMIs. They went from 25 to 31.9, so very high BMIs. And most of the individuals in those studies were actually middle-aged individuals. So the duration of the studies were 40 weeks, and in SURPASS 4 and 6, they were 52 weeks. And what were the primary outcomes in these studies? There were actually two: weight change in this heavy population and HbA1c drops. So the next slide is a bit of a complex one, and I'm trying to summarize 4 years of studies, okay? And I'll try in 5 minutes to tell you what these studies were about, and I hope everybody will be able to understand this. So we had tirzepatide, and it was actually in different dosings, okay? So there's a 5, a 10 milligram, and a 15 milligram of this particular molecule. And so they looked at populations who had diabetes and had tirzepatide in these arms in 3 doses, and then they looked at other parameters. Placebo, they looked at a comparator with semaglutide, with insulin, and then looked at the outcomes that we talked about, weight and HbA1c in these different arms. So if we look at SURPASS 1, we had tirzepatide versus placebo. And in these individuals with very high BMI, weight losses were 7 to 9.5 kgs. And weight loss, HbA1c drops went as far as 1.89% compared to 0.04 in the placebo. So you had HbA1c drops, remember we talked about insulin yesterday, up to 2.07. SURPASS 2 was published in the NEJM, looked at the same dosing of medication, but these were individuals who are already on metformin at 1,500 milligrams. And they did a head-to-head with semaglutide. So those 3 doses, and then a group on semaglutide, and found a HbA1c change of minus 2.3% in the tirzepatide group compared to 1.86%. So it was comparable, and semaglutide had studies already done before that. Then there was SURPASS 3 that looked at tirzepatide in a group who were already on conventional therapy of metformin and SGLT2, and they looked at insulin degludec. So this is the once weekly injectable therapy added on at different dosing. And in this particular one, you had weight losses of up to 12.9 kilos compared to the arms that used insulin who are at a positive 2.3 kg. So it was found to be superior to actually to using insulin degludec on an arm in people with diabetes. Now, so the SURPASS 4 had an interesting population because these individuals had established cardiovascular disease. So they had type 2 diabetes with established CVD, and they were already on metformin and SU. And on this particular study, they found that the adjudicated MACE, which was heart failure, hospitalization for heart failure, there was no association with excess cardiovascular risk. Remember, this is in the background of CVOTs that had already been done before. So we know about the safety of these medications and looking at a particular molecule. And finally, SURPASS 5, which had tirzepatide versus placebo, added to titrated insulin glargine. So in this particular population, the individuals used insulin that was titrated upwards. They compared to the tirzepatide group and found a HbA1c drop of 2.4% in the TZ group, and if you compared with placebo, less than 0.86. So statistically significant. So what was hot off the press last year was SURPASS 6. Okay, so there have been all these studies going on, and SURPASS 6 was published last year. And this looked at individuals who had type 2 diabetes and were poorly controlled on basal insulin. Okay? Then they took 3 arms with the various doses we talked about, 5, 10, and 15, and compared a population that were 3 times of these individual arms who were put on prandial insulin. So effectively a basal bolus regimen compared to a group who were on tirzepatide and basal insulin, simply put. This would run for 52 weeks, and look at the results. The HbA1c drop in this arm with the tirzepatide was 2.1% and a 1.1% with a basal bolus regimen. So comparable, actually very interesting with insulin, and I think the beneficial effect there is from the weight loss that comes with the particular molecule. The HbA1c drop was in the tirzepatide group, 68% achieved less than 7% of HbA1c compared with basal bolus at 36%. We attribute this, of course, to the weight gain that you get when you're using intensive insulin therapy. And finally, hypoglycemia events were 0.4 per 100 patients in the TZ group and 4.4 per 100 in the insulin lispro group. So safety and better HbA1c reductions. So in practice, what does this mean? That we can use these newer agents as potential for monotherapy in people who are obese. We can use them as add-on to conventional therapies. They have a non-inferiority as far as cardiovascular disease and MACE outcomes are concerned, and they do reduce HbA1c and weight gain compared with basal bolus regimens. But the most common adverse effects that we talked about yesterday were nausea, diarrhea, and vomiting. The second group was the SURMOUNT trials. Now, the SURMOUNT trials were done in individuals with obesity, mainly, but only one of them had people with diabetes. So this was looking at what do these agents do for obese individuals. They were double-blind again, multi-center, placebo-controlled, and phase 3 trials, same agent, but they looked in SURPASS 1, 3, and 4, there was no diabetes, so just obese individuals. And in the SURMOUNT 2, they had individuals with diabetes. Now, what is important in this one was that the BMI cutoff was 30, above 30, but look at what else they used as inclusion. A BMI of 27 with one other weight-related complication. And this is similar to our patients that we see. So they weren't really far out. And a HbA1c of 7 to 10% in these populations. And then the duration was longer than in the SURPASS trials. And the primary outcomes in this particular one, remember, most of them didn't have diabetes, was just a weight loss or change of over 5%. So what were the summaries of these studies? In SURMOUNT 1, just like they did in the previous one, they looked at tirzepatide at 15 milligrams versus placebo. And look at that weight loss of 20.9% of your body weight at baseline compared to 3.1%. So quite a lot of weight loss, which changes a lot of metabolic parameters and the potential for improving your cardiovascular risk. This was in the background of STEP 1 study that had been done with semaglutide and placebo earlier that showed a 14.9% reduction of weight. SURMOUNT 2 went on to look at individuals who had obesity and diabetes, so this was also published last year, and they had the 3 arms, the tirzepatide 10 and 15 versus placebo. And again, very good weight loss, means 14.7% in the tirzepatide arm in the 15 milligram, compared with 3.2 placebo. And an average weight loss target was achieved over 5% in 83% of those who actually got to these maximal doses compared to placebo. And these were done, the conclusion of this were done with very good safety profiles. So let's go on to SURMOUNT 3 that has just been published and hot off the press. Now, simply put, these were individuals who had 12 weeks of intensive lifestyle, okay? So they've got exercise regimens, they've got calorie restriction, and then they divided them into 2 arms and randomized 1-on-1. And you can see in the blue panel down there, individuals who continued on the tirzepatide, and then individuals who just continued with their normal lifestyle. And it's interesting that those who continued with tirzepatide were able, 44%, to achieve 20% more weight loss from an intensive lifestyle at the time, from the time of randomization. and a total mean weight reduction of 24.3%. The backdrop of this is the question as to whether these medications should be used longer term, because now obesity can be considered a chronic disease in itself. So that's the question here. Then we have Surmount 4 that has just been published also, and this one had a 36-week lead-in. And that means that the population were given an intervention, which was tirzepatide, and then after the 36 weeks, they allowed them to go on placebo and followed up for another 72 weeks with tirzepatide on board. And these individuals had an additional 6.7% weight reduction after randomization and a mean weight gain, regain of weight in the placebo arm. So when we stop these medications, weight goes up. That's your take-home point here. So tirzepatide has been associated with weight losses of up to 26%. There's additional benefit of intensive lifestyle at 12 weeks, up to 12 weeks, and substantial benefit of cardiometabolic risk. But we need to consider what happens when we stop these therapies after using them, and how long should they be used in the modern day, and cost remains our challenge. So those were the practices of Surmount, or the practical applications. So the Coordinate trial was another big trial in 2023. So Coordinate was a randomized cluster effectiveness trial that looked at usual care, 43 clinics, and they were divided into an interventional arm and usual care. And the aim of this study was to look at whether we can intervene and affect practice of evidence-based, use of evidence-based therapies. And in this case, the primary outcome was to see in this clinic if a multifaceted intervention, which included phone calls, included giving guidelines, included mentorship on why we were giving these medications, would make a difference compared to just giving people a 2024 guideline, okay? And they looked at whether high-intensity statins were used, a GLP-1 and an SGLT2 with cardiovascular benefit, and an ACE-ARB. What was the primary outcome of this? And what were the results? In usual care, only 14.5% prescription patterns were there, compared to 37.9% in the clinics where they used the multifaceted intervention. So an absolute difference that was significant of 23.4%. However, in adjudicated MACE outcomes, there was no significant difference with adjusted hazard ratios of 0.79. So in practice, our implementation of guidelines will need some multifaceted intervention for it, I think, to be applied and used in clinics. The DIRECT study was another big study, and the summary of this study, this was on the backdrop in the UK, 2014 to 2016, a study was done where they took individuals and gave them calorie restriction, lifestyle modification, and followed them up for 2 years with withdrawal of their medications to see whether remission would be maintained. Okay? That was the backdrop. And after this, they extended this to 5 years to follow up these individuals, and they were put into 2 arms. Those who got a gentle follow-up of the instructions and interventions that had been there, and the others who just continued living life. The outcome of this was that 26% remained in remission at 5 years, compared with the 36% who were in remission at 2 years. So remission goes down with time. However, the benefits, even in the times of remission, of cardiovascular and otherwise, were found to go through the groups. So any time of remission or intensification of glucose is beneficial in the long run, and the serious events ratios were 4.8 per 100 patients per year for the patients who continued on this follow-up, compared to 10% in the original group. So we will be winding up this presentation with the new nomenclature of NAFLD versus MASLD, and we've already had a backdrop presentation this morning, which was excellent. And I think what has changed in this is coming from NASH, non-alcoholic steatohepatitis, and now we have metabolic dysfunction-associated liver disease, okay? And simply put, is that now we are able, with certain parameters and the FIB4 index, to look at metabolic as a cause of liver disease. And we have criteria now, you can see in this middle panel, that can actually calculate how much alcohol you're using and determine if a person is actually in closer to a parameter that causes it to be called a metabolic associated liver disease. So there's an overlay there that now we have defined. And then the others are alcoholic liver disease, which is predominant on its own. You can have cryptogenic and specific etiology liver disease. So just a change in nomenclature. And this busy slide here just basically shows that if you have certain criteria in anyone who has fatty liver, if they have a high BMI, high glucose, blood pressure, or a TG that is high or a low HDL, plus abnormal liver functions, you can start to categorize them. So does the patient meet metabolic criteria? If yes, are there other causes of steatosis? If no, then you just call them muscle D. But if they have other causes, then you think about alcohol and use the chart that we talked about earlier, and they could have metabolic associated liver disease. If they don't have any metabolic criteria, they fall into the standard other panels. So what we call the FIB4 index now is a simple parameter you can use in your clinics, and is a score of age, AST, ALT, and platelets. And then you calculate a number. And from that number, if you have less than 1.3 on the FIB4, you're lower risk. Okay? And that's a patient you can screen after 2 years. If you're over 1.3, they're intermediate risk and individuals who should go for elastography or imaging of some form. And if you find that there's a liver stiffness measurement that is less than 8 kilopascals, then these people are low risk and you can repeat. If it's over that number, then those are high-risk individuals who must go for a biopsy. So better classification that make it easier for us to take care of these patients with NASH. Now, the other entity that was there last year was something called sarcopenic obesity. So this is where a comparator is made with visceral fat compared to skeletal muscle. Okay? Very important in nutrition. And why this is important is that it's not enough just to be slim, that these factors, if you're obese, you could be tiny but still have more visceral fat than skeletal mass, and that gives you a risk for inflammation, glucose dysregulation, lipid dysregulation, and also reduced mobility and falls. So in these people who we have frailty, you need to think about time in range at different levels from the normal population, but the time below range should be less than 1%. Another thing to note on this is that you can have sarcopenic obesity, you know, with sudden drastic weight loss with these medications, and we are losing sudden skeletal mass. That's another group that gets a new form of risk to think about. So my final slide is a summary of the 2023 guideline changes that looked at the importance of the role of community health workers, the utility of point-of-care testing of HbA1c now being utilized more. In statins and diabetes, there was the thought that we now need to think about lower intensity statins in older individuals, and the use of pioglitazone in stroke and pre-diabetes, and intensive pharmacotherapy and lifestyle like we've been discussing to promote outcomes, and finally the FIB4 index that we talked about. So thank you, ladies and gentlemen. And my next speaker is coming on, Dr. Rilwan. And she will start us off with the AI and as the second part of this presentation.
Thank you so much, Prof. A disclaimer, this is not my usual voice for those who don't know me. But I think just taking off, so I've been tasked to talk about AI, and I'm sure you all know what AI is, but AI is not new. Probably most of us think it's new, but it's from the 1950s, 50 to 54, I think a guy called John McCarthy brought out the term AI, and basically, so here we've been brought here today by diabetes. So if we're talking about AI and diabetes, what does that mean? So we'll go to, my objectives today basically is, what is AI? And the gaps that AI fills in managing our diabetes patients, the various tech apps that are being used, web-based remote monitoring, electronic health records, challenges with diabetes, tech and the ethical considerations, and what the future holds. So, what is AI? So basically, AI is technology that enables computers and machines to simulate human intelligence and problem-solving capabilities. So basically, it's what we do as humans that we're trying to make machines do. So, and when we're talking about AI, so before I come to how it works, there are subsets of AI. So you have machine learning, you have deep learning, you have neural network. So basically, what does this mean? So for machine learning, it's you inputting data in these algorithms that were made so that it can learn and it can be able to interpret and it can be able to pick up patterns and hence predict what is happening. So deep learning is a subset of this machine learning, which just means that for more complex situations, there is some sort of, the way the neurons work in the brain, neuronal connections to be able to predict further. And natural language processing. How many of us have used Siri or Alexa giving instructions? Like you're driving and you're like, Alexa, take me home. So basically, this is natural language processing. Yeah. So this is natural language processing in the sense that this computer can recognize your voice and can take instructions and is actually intelligent enough to give you directions to go home. When it comes to computer vision, it's this computer being able to recognize visuals or pictures. Like in the setting of diabetes, for the AI retinal imagings that it picks up and it's able to determine that this is a retinopathy, this is not a retinopathy. So for this, it's the use of computer visions. Basically, what happens when we're developing these algorithms is you get the user experience, the UX. So the doctor goes to a developer and says, I want this to happen. In the sense that this is what I usually do, I see my patients, this is what happens. And so they develop a code which just gives instructions. And it means you do what? You input data. So the various data sources that you have, for example, for us doctors, is our electronic health records or our files, where you have the history, you have the physical examination, the lab records, the imaging. So you input all this data. So to bring it holistically, not just focus on the hospital records, but also the lifestyles. You have the devices, your Apple Watches, which are picking up your physical activity, your diet, what you're eating, that you input in various apps to be able to predict for you your carbs and calculate for you your carbs. You have the social determinants of health, your environment, the weather. So all this, when you input into a certain algorithm, this is how it works. So you input all this data into the AI algorithm, and it can learn over time. So you have the prototype where you put it in, and the machine learns, and with time it recognizes patterns, and with this pattern recognition, what happens? It can make predictions. And with these predictions, you're able to make your decision, or you're able to perform tasks. So this is mainly how AI works. So somebody in the workshop yesterday talked about data. So data, I'm sure we've all heard this phrase, is gold. And so you are all sitting on a gold mine, because developing this, when you use that data to develop your own algorithm and make your machine learn, you can be able to predict, you can be able to make decisions based on these tools. So what gaps does this fill for you in your day-to-day management? So just imagine your daily clinic. A patient comes in, so what do? You have to make a diagnosis. With time, you have to monitor this patient as you follow up. You have to treat this patient. You have to prevent complication or predict complication for these patients. And for our diabetes patients, there are some who will need insulin, and you'll need to deliver insulin. nutrition, and education for our patients. So this is basically what we do for our patients. What I need to tell you right now, as we're sitting here, AI is helping us do this. So what happens for majority of times when we're in the clinic, we have challenges making probably a diagnosis, not diagnosis of diabetes, but probably what type of diabetes does this patient have? Type 1, MODY, LADA, type 2. So we have algorithms that have been developed, and there is one here by University of Exeter. This is, how many of us have used MedCalc? So you just input and it just calculates for you. Same thing here. So if you want MODY, you just go, you click MODY, you put there patient's age, patient's BMI, patient's race, patient's gender, and you just hit calculate. And it will tell you high probability of MODY or low probability of MODY. So this will guide you. Would you send this patient for this expensive genetic test required for you to get an absolute diagnosis of MODY? So this is actually going to help you in terms of making an absolute diagnosis for this patient. So other forms of predicting diabetes are coming up. This was published last year, just using X-ray, looking at X-rays of patient and just predicting type 2 diabetes from an X-ray. Another there, just from voice recognition, acoustic analysis, just the pitch of the different voices being used to predict type 2 diabetes. So the algorithm was made, just voice, and the patient is told, oh, you have a high probability of developing type 2 diabetes eventually. So this is where we are going. This is where we are. So we need to embrace it. So when we come to monitoring our patients, look at historically where we've come from the 15th century. Just patient having polyuria was just a way of you saying this patient has high sugars. Or patient has peed and there's ants following the pee and you say, oh, there's a lot of sugar in that pee, so definitely high sugars. And come to the 19th century where you have the various tests being done on blood, using blood and urine, and the glucometers eventually. And obviously, coming into the 21st century, we have the CGMs. So CGMs are here with us, we're using it now, but as of 2019, we've had now the story of non-invasive blood glucose monitoring. So there is no more pricks anymore coming up, so watches and all that telling you your blood glucose level just from non-invasive procedures. So this is how far we've come in terms of monitoring patients. So in the near future, you'll hear that patients don't have to prick themselves in terms of monitoring their sugars. So the monitoring challenges we've had over time, it's complex systems. A lot of my elderly patients still can't use the glucometer because some of them are not literate and cannot record for me, and pain associated with the pricks, obviously, and blood. And over time, we've had the wireless, the pain-free, and the alarming systems. Now, mothers can sleep peacefully because they know that they'll get an alarm and their little babies will not go into hypos. So the various forms of technology there in terms of monitoring, we have there, as you can see, the glucometer from the previous times, and still here with us now, at least in our part of the world. And then we have the CGMs. Currently, the current one from Freestyle is the Libre 3 there, and we have the Dexcom G7, which is also the current one. So when we come to now CGM reports, how have CGM reports helped us? They're more accurate. Why? Because they're real-time sugar readings. Patients don't have to keep pricking themselves, and they can see their sugars right there and then. And even over long-term monitoring, what we can now call the time in range, it is more accurate than obviously the HbA1cs that we have, because if you can see there, the HbA1c gives, when patients have a lot of glucose variability, we can still get a HbA1c which is near normal, when in actual sense the patient is not well controlled. So with time now, there is a shift to move from the HbA1c obviously to the time in range, which is more accurate, because the time in range tells you that over this time, this patient has been in the range, in the target in which you have set for your patients. So if a patient is 70% time in range, you know they're doing well. Time above range, if they're 80% and above, well and good. And it even gives you time below range. So that is a more accurate factor in terms of monitoring our patients. And then now, as we have these sensors and the CGMs are monitoring these patients in real time, now the insulin delivery becomes easy. Why? Because you have the closed loop system which communicates with the pump. And with the pump, it delivers the insulin based on the sugar readings. And if the sugar is low, it tends to to suspend the insulin delivery based on that. And artificial intelligence comes in again, because with the closed loop system, now I know Gaman uses it a lot, and he has to have input for his patients, in the sense that closed loop system, the automated basal insulin. So the bolus is not automated. You have to put in the carbs for you to be able to calculate the bolus. There is that input which they still have to do. So an artificial intelligence-based system was actually compared to physicians' input, and it was found to be comparable with what the physicians are doing. So artificial intelligence is still doing what we're doing here there as well. And then comes the other form of delivery of insulin, which is the smart pens. So the smart pen is basically the usual pen that we use for now, but the difference is it has a battery, and the battery has a half-life of about 1 year, and it's connected to a Bluetooth app. So with the app, you input the sugar. And you get to put the carbs. So what it does is it automatically calculates the bolus for the patients, for those who are on MDI, multiple daily injections. This only works for the bolus insulin. It does not work for the basal, so you'll have to give your basal as normal, but it is helping calculate the bolus doses for the patient, in the sense now that now becomes automated. I think Medtronics have the Guardian Connect connected to the app, and so the sugar readings, the patients don't have to input it, and so they just get the carbs that they put in, almost just similar to the closed loop system. Only difference is that it's not the automated basal, the closed loop, it's automated bolus. So that is the features of the insulin pen. And now we come to the prediction and prevention of complications. We have the acute complications there, which obviously technology has helped us in terms of giving us the alarms, and in terms of giving the autocorrect when the blood sugar is high, like with the closed loop system, and obviously suspend of insulin when the glucose is low, and obviously monitor the active insulin. And even with the smart pen, you can actually see the active insulin on the app. And so predicting chronic complications, I'm sure most people know about the retinopathy. The cameras attached to the iPhone, and you can predict that. We have a study going on at Lions right now, actually, with the retina surgeons regarding that, developing a tool for predicting. It will actually reduce our time for the ophthalmologist to actually go there and just dilate the patients and have a look, and we'll just put the app, and if the artificial intelligence system detects that there is retinopathy, we just send them over. So that actually is helping. So we also have an AI system which we are using at our foot center at Lions. It is guiding us in terms of managing the wounds at the foot clinic. We have AI being used for peripheral neuropathy and also diabetic nephropathy. When it comes to nutrition, obviously, I'm sure this is all online. If you've tried some weight loss, Googled, and that's why I'm saying you're using AI daily, because you Google something automatically, if you're on Facebook or you're on Twitter or you're on any other social media, you get feeds that come on regarding what you searched. So I'm sure you've seen a lot of nutrition ones where you input your data and it automatically calculates for you your carbs that you need to get to a certain weight, and it gives you this virtual coaching, and it tries to predict for you what you should eat to get to a certain weight. Carbs and cal, quite common in terms of carb counting, especially for our patients, which we've been using over time. And diabetes education, this is quite useful to us because it will reduce the loads in our clinics. And this is now personalized. Patients input their data. All I'm talking about is data. You input your data and you get these interactive chatbots talking to you like it's personally you. It's not generalized. This is talking to you based on you and your needs, and it's taking you through your journey of diabetes like it knows you on a personal level. So, and the virtual coaching, I think, is actually also going on, and that's a site which usually provides diabetes education with remote monitoring. I don't have to mention that, telemedicine, and we all know that. We have an app at Lions which we use for our patients in the mashinani, and it's quite useful, and we can see their sugar levels from the clinic as they call in, because it's sort of remote monitoring. All they need to do is to input their sugar, or if they don't input their sugar, we have a machine, that they input in their phone, and it automatically gives the sugar reading. My elderly patients really love it because they don't really have to write the sugars. They just put their drop of blood and it's on their smartphone, and I can see it from my end, so it's quite useful. And then electronic health records. This has been, especially for those with private practice, it has been shown the AI EHRs have been shown to reduce clerical work in terms of administrative, in terms of financials, really helping you to push your practice further. But not only that, if you have your patient you're seeing in the clinic, your file in that EHR, and when you admit them in the ward, all this collated actually through AI, it actually gives predictions, sometimes even like the predicted admissions for these patients, predicted outcomes for this patient. So it's actually quite useful in guiding management of our patients. And with all that, we come to this, the digital twin. What does that mean? You have your physical patients who you've collected all this data from, is in a repository somewhere. The machine has learned all the patterns, and it's now helping you predict what is happening. It predicts the patient's management and also guide in terms of their future predictions in terms of complications and all that. So this is what we're looking at. So you have your physical patient and you have the digital twin, which is actually in your system, and you can be able to accrue to that. And the thing I like about this is that it's not only the medical aspect, the social aspect, because sometimes we're in the clinic and the patient comes and tells you my insurance has run out. This actually gives you alerts in terms of this patient's insurance is at this level, so it even guides you in terms of therapy, like what types of medications should I give based on this patient's insurance and all that. So it's actually cut across. It's not only the medical aspect, it's holistic. Ethical consideration, obviously data privacy. I think the Data Privacy Act of 2019 has helped in guiding how we deal with this. And then there's the algorithm bias. I think all these trials Prof was talking about were being done in other parts of the world. And I think there's a lot of talk around health equity right now in terms of patients we enroll in clinical trials. Do they really represent globally our patient profile? And is this is still happening even with the AI, because this is sort of a selection bias. The data that's being used to teach these machines, or the machine learning, or the models that are being built, are actually data from mostly other parts of the world. So we need to build our own, and this is really quite easy. You just get a developer and you just have a tool that they will create for you, and you'll just input this data and the machine will learn. So to reduce this algorithm bias, we need to put in terms of not only the racial, the gender, but also different society in terms of the community cut across, so that we can be able to have a robust tool which covers the whole community at large. And then obviously human oversight. Challenges. These are tools. We need our senses for the patients who are visually impaired, hearing impairment. I'm sure the patients who have hearing impairment can't use Siri or Alexa. And so there are all these things that you look at in terms of the challenges with technology. And so our take home is AI is revolutionizing diabetes care. Not only diabetes care, it's actually across all sectors. If you look, financial, every part of the society. So it's here with us. It will help us in guiding our management in terms of early detection, personalizing treatment, enhancing monitoring, and also patient engagement with the tools that are available for our patients to use. So look at it this way. You have an interface, which is the doctor interface, where you are inputting the data, all this data, and then you have a patient interface, which the patient is available to the patient with their data through yours. The interface that the patient has is not your interface. So through this machine learning, the patient can be able to get personalized care at the palm of their hands through the data that it was input in the patient, in your side, or on your side, sorry, and you can be able to guide them just from the comfort of their home. So where are we going with all this? So you have your human brain there, and you have the AI brain there. So how many of you think that us healthcare professionals will be jobless soon because of all this? Oh, some people do think, yeah? So, exactly, Rosie, the human touch. So there is something AI will not do. AI will not give empathy. So I think that would be the biggest difference. And AI is not a threat to us. I believe that AI will not destroy humanity, but it will augment. It will help us become more precise in terms of how we manage our patients. So I think we should embrace it, and I think we should start being innovative. We're sitting on a gold mine in terms of data, and we don't want people from outside coming to pick this data. I think we can utilize this, and for next year's Kdsg, I want an AI presentation here in terms of using our own data. Thank you very much.
Thank you. I've been assigned. Is there a moving mic? Can I have a moving mic, please? I've been assigned to talk about what's new in tech in the year 2023. As Nancy alluded, we are really looking at what we thought was useful and may have left out other things. So this is my point of view, or what I think was useful. So we are moving now. You know about continuous glucose monitoring. There's now a new term called continuous ketone monitoring. So do we really need to look above or beyond blood glucose? Currently, in our system, or in our care, we have these ketone monitors that monitor sugars at that particular time. But there are situations when our blood sugars are normal and we need to continuously monitor ketones, such as patients on SGLT2s. Now we know this will be used more in type 1 diabetics who are at high risk as well, patients who are pregnant, ketosis-prone type 2 diabetics. So the issue of monitoring ketones is going to grow, and the issue of continuously monitoring ketone is going to grow even more, because we know if we know ketones are climbing, we can prevent impending ketoacidosis. So the ketone monitors are just like our CGM monitors. They have a patch. You have a phone device that picks up your trends and is able to alert you. From these two next slides, we know that people don't test their their ketones as often as they should. Here, this looks at adults really not testing. About 50 to 60% of adults do not check their ketones when their sugar is above 16. If we look at the next slide, people who are vomiting, you look at a large percentage of them are not testing their ketones. It's the younger kids who their parents actually motivate them or move them to actually test their ketones. So the message here is we're not testing ketones enough, and we may need to look at that, and probably the way forward is to have a system that actually does that for us. Now when we look at our patient instructions for ketone testing, you tell them you have impending decay when your ketone is above 1.5. You can start then having your insulin, take your snacks, do something about it. But what the new data that's coming out is that probably we need to rethink this. This is data from type 1 diabetics, and it picked up that a ketone level of 0.8, it gives you threefold risk of decay. This means our conventional thought that we need to start worrying about a ketone level of 1.5 may change with more data as it comes out. So maybe a ketone level of 0.8 would need someone to start intervening. But how will you know this if you don't have a monitor on? And this is where we are driving. So there will be indications where we need to use continuous ketone monitoring, or a sensor that's on that's telling you your ketone level is 0.5, such as patients with recurrent decay, in pregnancy, on non-diabetic forum, people who are on low-carb diets, who are on metabolic diets, people with anorexia, during exercise, sick days, and of course, I think the SGLT2, although it's off-label in type 1 diabetes, with all the data that's coming out, probably we'll be using it much more in type 1 diabetics, and maybe this may be a tool that will be useful for them. So how would the alerts come? You would get an alert on your phone saying impending decay, follow this following instructions, and I think this is probably something that we will see happening. Now let's look at the artificial pancreas, and we're going to start from where we are and probably where we are going. Currently, we have what we call hybrid closed-loop systems, and I'll just give you a brief. The hybrid closed-loop system is able to deliver insulin automatically based on your blood sugars. Your blood sugars are higher, it gives you more insulin. Your blood sugars are less, it gives you less insulin. It's linked to a sensor. However, the hybrid closed-loop systems use one hormone, that is insulin, and the hybrid closed-loop systems do not deliver an automated bolus when you're feeding. They can do a correction bolus, but they don't give you a meal bolus. And there are three main systems that are there: the Medtronic 780G that we use here, the Omnipod, and the Tandem T-Slim with control IQ system. But we now have, or we've had, the bihormonal artificial pancreas. The bihormonal artificial pancreas, the size is about this. It's an external device. If you look at it's about this size. It has insulin and glucagon. It has two delivery tubes, one for glucagon, one for insulin, two sensors, and it's gives you more stable glycemic control. So the guys who watch F1 here, let's say if you had a Ferrari or a Mercedes that now had sensors that would stop it from crashing at corners. You could just step on the accelerator and you're not worried about crashing into the corners. With glucagon on board, the algorithms are able to be more aggressive, and this is the difference that is there. So this is a study from INREDA AP. It's a study that was published this year on a bihormonal fully closed loop system. A fully closed loop system is a system that you don't do anything. You eat, you don't inject, it does everything for you. And this was a study on 82 patients, a 1-year study in 8 centers. It was a home study. And here we had an A1C, a time in target moving up to 80% time in range on a fully closed loop system. That is very, very impressive. And of course, the time below range of about 1.3%. Now, if we take this data and say, okay, how does it compare to what we have now currently, which is the hybrid closed loop system? The hybrid closed loop system gives you a time in range, and time in range is basically saying how long are you between 4 and 10. The current systems give you 70, 75%, maximum 80%. This gives you between 80 and 90% time in range. If you look at the data, I just tried to summarize it there. What about the A1C? With these newer systems, bihormonal, you can drive faster, you have more algorithms to avoid hypo and hyperglycemia. Your A1C is between 6.5 to 7, compared to conventionally about 7% or so with the other systems. Again, this is just showing you, for those guys who want to see the system, that's actually a picture I took of the system. You can see 2 sensors, 2 delivery, but it's a bit bulky. What about hypoglycemia? The bihormonal artificial pancreas gives you 50% reduction in hypoglycemia or time below range compared to the conventional system. The conventional systems, or what we have now, is less than 4%, 3.5, 3.6. This can give you up to 1.3% time below target. So this is pretty impressive when you look at the data out there. Already, the conventional systems do reduce your hypoglycemic risk by 25 to 30% compared to conventional MDI. But the main challenge is the user experience. The device is about the size of this card. It uses 2 tubings. It uses glucagon. Glucagon has a problem with stability, and there are new glucagon molecules that have been put together, but the availability, that would be a challenge, and of course wearing 2 sensors that are there. So this would be, I think, the limiting factor. Now, Rilwan talked about the CGMs in the market. Where are we in terms of our CGMs? Our current CGMs, which are about, the main drivers are around 4 in the market: the Dexcom, the Guardian system, the Libre, and the Eversense. The Eversense is an implantable CGM that you wear on your arm. It's like a little bit like a no plant that you put in your arm and lasts between 3 and 6 months. This mainly looks at retrospective data. So let's say I'm standing here, or I'm in a meeting that I'll be in for 1 hour. I'll know if I'm going to have a hypo, like the time I'm having a hypo. But now we're looking forward ahead, because we realize what patients want. They want a prediction. And there are challenges with our current CGM. It does not give you a prediction. If you're sitting in a meeting, you'll get the alarm that you're going into a hypo at the time you're going into a hypo. But wouldn't it be nice to know in the next 2 hours, you have a high risk of having a hypo, and then you can plan better. If you're going to bed, you know that 4 o'clock I'm going to get a hypo, so you take a snack. Now, when you have, or you avoid a hypo and you avoid alarms, remember one of the distresses of CGMs is alarms. People have alarm fatigue. It's always buzzing away. They'll tell you it's always buzzing away, and you have got to set your alarms higher. But if you have a prediction that something is going to happen, and you act on it way before, you avoid alarm fatigue, and you are allowing all these challenges that are there with our current CGMs. So we have the the AccuCheck Smart Guide, and it's a simple thing. It's a CGM with a phone, but now has a predictive app, an app that can predict what's going to happen. And it predicts 3 things. It has a glucose predict, a low glucose predict, and a night low predict. All these are AI enabled. Okay. The input for all of this is time of the day. For example, for glucose predict, the bolus insulin, and the recent and historic glucose and carbohydrates. This is for the glucose predict. So it predicts the future glucose excursions up to 2 hours. So you can say, the next 2 hours, I'm going to have a spike, so I need to do X, Y, Z. Then there's the low glucose predict. This looks at your recent glucose, the carbohydrates, and it gives you a prediction for the next 30 minutes. And here you have a push notification. It comes in as a push notification. Then you have, and I think this is what people will really love, the night low predict. And for this is where AI comes in. It looks at your historic glucose excursions, past nighttime hypoglycemia, how much insulin you bolused, your nighttime hypoglycemic risks in the past, and here you have a nighttime hypoglycemic risk prediction of 7 hours. So let's look at this a little bit further. We know trend arrow calculations. When the normal CGM tells you you're having a low, it's really based on an extrapolation. It sees your sugar is coming down, it says you're going to have a hypo. But it's not always like that. With the prediction model, you have the individual subject data. There are several features that come in. How many carbs have been taken in? How much insulin has been taken? What's the history overnight? What's the sensitivity to insulin overnight for this particular patient? Are they more sensitive in the day than at the night? This is what happens. So there's something called fuzzy logic. If this, then this. If this, then this. With this person, this. So this is what goes on at the back, and it can predict the glucose profile. So here, this just goes to show you, maybe I can come, yeah. Here, if you have a trend profile, maybe, it doesn't, huh? No, it doesn't. Oh, no, but not on the screen. Okay. Can I maybe, let me see. Doesn't. I'm okay. Okay. So basically, I would like you guys to focus on the last two, or what's on the right-hand side. That's the predicted blood sugar. So you can see, although your sugar's or at a certain level, you can predict to go up, or you can predict to go down. So here, and then it gives you your mean prediction. So you can actually look at your smartphone and say, I can either be here or here overnight, and I can take something to prevent a low or prevent a high. So what would you have? And I'm sorry, is this, for those of you who have Samsungs, do not worry, it will also work on a Samsung. Oppo, yeah, or even Oppo. Yeah, I know us iPhone guys like, showing off a little bit. But you see, here you can have your low glucose predicts. So it will say high probability between 12:30 and 1 o'clock for you to have a low sugar. Look at that. It's an alert that comes up and says, what can I do? Have some dextrose. Or you're going to bed and it tells you, you look at your phone and you say, I have a low probability today, it's fine, or I have a high probability, let me do something about it. So can you see how we've moved forward now from just saying, my sugar's 6 right now, or 7 or 8, I'm going to bed, to saying, listen, you know what, at 3 o'clock in the morning, I may have a hypo. Let me do something about it. So it can be used in anyone above 18 years. That's what they're aiming with their CE approval. It can be used on patients on MDI, on continuous subcutaneous insulin infusion. These are patients who are not on, let's say, any hybrid closed loop system, because the hybrid closed loop system does this for you. And as I mentioned, it looks at these 3 things: 2-hour glucose prediction, low glucose prediction, and night low glucose prediction. So in the past, our challenge with insulin has been really delivery. No one wants to have insulin shots. And there have been several delivery modes that have been attempted over the past years. Jet injectors that have insulin that they use pressure and it goes underneath your skin. We've had issues with irritation, pain. I've even tried one. It's not a nice device to have, but if you have needle phobia, you can have these challenges. Then came in inhaled insulins. Now the story of inhaled insulin starts in 1925. That's when it was first mentioned. It was mentioned because the surface area of the lung is like the size of a tennis court. So it's a very good area to deliver insulin. But there were respiratory challenges. When I started my training, there was an inhaled insulin called Exubera in one of the multi-center study sites, and we were actually enrolling patients. And what we found is that even in non-smokers and patients who had normal lung functions, 6 months or one year down the line, they had lung functions that had deteriorated. So we never thought that these molecules would take off, and they didn't really take off. Even the small Afrizi, which is an inhaled insulin, we are torn between, was it taken off because of price? We're not very sure what exactly happened. But I think these inhaled insulins probably had issues to do with lungs, respiratory problems, so they didn't really kick off. Then we have, and I think, I'm sorry it's not here, but I put it on, there was something called the iPort, which is a small tube that you place underneath the skin. It's like something you inject. It's got a rubber covering, and you inject in there for patients who have needle phobia, and we have used it locally, but the cost was pretty prohibitive, 20,000 a month. So you have that cost versus your insulin cost, and I think it didn't really kick off, and overall it hasn't really kicked off. So the iPort is like just a delivery device, that a delivery port that you can give insulin. So then comes now our transdermal delivery devices, and I thought I'd just talk about it because it would be interesting to know, will we ever get to a stage where we don't need to inject? Traditionally, it has been difficult to give medications transdermally because of the size. Delivery so far has been only on molecules that are less than 500 Daltons. That's roughly, 1.66 times 10 to the power minus 27 of a kilogram. How much would that be? 27 zeros. Okay, so really we have a challenge with larger molecules, and now we have devices that allow dissolution extracellular of deposits, and this probably would be interesting to see whether it does work out. And we have studies in rats now that have patches with insulin and even semaglutide. So following subcutaneous injections and patches, they found similar drug levels for both semaglutide and for insulin. Whether this takes off or not is a question to be answered in the future. So to summarize, hit or miss, what are my predictions going forward? I think continuous ketone monitoring will be a hit with time, because there is the need both from the diabetes fraternity and the non-diabetes fraternity, just as CGM. And as I said, as we move along with some of the newer molecules that come around that require to monitor glucose, especially in type 1 diabetics or ketosis prone, this will be something to look at. I foresee a sensor that does both CGM and ketone monitoring coming together. Predictive CGMs, I think it is logical that we've moved away from saying that retrospective data is good enough. We want prospective data, something to give someone a normal life, someone to allow someone to say, listen, I need to do X, Y, Z, you know, I'm going low or I'm going to go high. The bihormonal pancreas, I think, is exciting. Remember, timing target above 80% or so is fantastic. It is really unbelievable. But are we able to wear a device that is this size, unless it gets smaller, have 2 tubings, have 2 sensors, have to put in glucagon that we are not sure whether we can get easily? That's my question mark. Transdermal, it's fantastic. They're still very early studies. What will happen? Will there be reactions? Is it really sustainable? Will it only allow provision of basal insulin? So all those are questions that probably have a lot to be, you know, answered as time goes by. Thank you.
It's exciting, right, in the field of diabetes. But Rilwan, we refuse to be replaced by AI. And Gaman, proud Samsung user till I die, okay? So I'd like to encourage you all to furiously write questions. I'm sure for this flashback, it's generated quite a number of questions. So instead of having the Q&A now, in the interest of time, please write down your questions. We'll have the Q&A after our next talk. Now, I'd like to invite Dr. Mushai Gashago. He's a consultant ophthalmologist, vitreoretinal surgeon, and medical educator. And he's going to tell us whether he's going to be replaced soon by AI, kidding. But he's going to talk about red flags, retina, and referral, and its role and how we work together between the ophthalmologist and the diabetologist. Karibu, Daktari.
All right, good morning. Yeah, it's an absolute pleasure for me to be here. I think this is my second Kdsg meeting. Thank you to the organizing committee for inviting me as an eye specialist to come and have this great time with physicians, diabetologists, as we all try and make headway in the management of diabetes and its related complications. My name is Dr. Mushai Gashago, ophthalmologist working at the City Eye Hospital in Nairobi, and also the chair of the Vitreoretinal Society of Kenya, which is an amazing boutique society with a membership of 10. And I also work with the College of Ophthalmology as the exams lead. I'm feeling at home, being that this is not my first meeting, and after looking at your manual, I realized there were 2 ophthalmologists who are founding fathers and mothers of Kdsg, Professor Gishuhi and Dr. Choksi. So I'm feeling even more at home with that now. So we'll talk about the 3 R's in terms of red flags in retina, and then the retinopathy, and also about referral patterns. All right, so as an introduction, that's what we shall go through. And then those are some of my, let me call them financial disclosures, although none of them is really relevant here, although all these companies are involved in the production of drugs that we use regularly in the management of diabetic retinopathy. So Henry Ford said that there are no big problems, there are just a lot of little problems. So we'll start with that quote and revisit it at the end of the presentation, because I remember not too long ago making a presentation on how big a problem diabetes and diabetic retinopathy was. So this quote challenged me to think about it a bit differently. So when we talk about diabetic eye disease, I first want to distract you a bit, because when we hear of diabetic eye disease, we just go straight to the retina. Diabetes does a lot more to the eye and the visual system than just diabetic retinopathy. So starting with simple things such as dry eye disease. We get a lot of dry eyes in our diabetic patients, and sometimes it's related to neuropathy, related to the sympathetic supply of the lacrimal glands, which are important in the production of tears. Then as you talk about slow healing feet with the podiatrists, we also have slow healing corneas. If a diabetic gets a corneal ulcer, and this happens sometimes in the course of surgery or because of an infection or trauma, expect that you normally get persistent epithelial defects, some of which completely refuse to heal. And you can have done amazing retina surgery, and you failed to adequately hydrate your cornea, and you lose that eye because of the cornea. Then, of course, cataracts. We have a higher prevalence, earlier onset and higher prevalence of cataracts in diabetics. Then we have also found a higher prevalence of glaucoma. I can't fully explain it. I think there's changes in the trabecular meshwork associated with diabetes. But I did a study on glaucoma in around 2010, 2011. It was my thesis, and 80% of my glaucoma patients were diabetic. I don't think that was a coincidence. 80% was just too high. Then, of course, the neuropathies. Acute non-atteritic ischemic optic neuropathy, quite common, many times confused with glaucoma, especially when it goes to the chronic phase of optic atrophy. As you can see, like in that case, patient who started off as a neon ended up with optic atrophy. So that is quite common. And you see the supply to the optic nerve and the retina are pretty similar. So you get these patients coming in with proliferative retinopathy, you manage, do surgery, do intravitreal injections, and when finally it settles, the optic atrophy that was coming from the back forward then hits the eye. So you've got a perfectly settled retina with a pale optic disc, and you wonder what the effort was whether it was all worth it. But yeah, that is quite something we see quite often. And then, of course, other cranial nerve pulses that will be associated with other complications of diabetes. So now let's look at the red flags for diabetic retinopathy. So I've discussed the other aspects of diabetic eye disease, so that now those set aside, and let's look more at the retinopathy. So when we look at the red flags, for me, one of my first red flags is when the patient comes in and I ask them, who is your physician? Or where do you go for your eye clinic? And the minute they start stuttering, no, not because they are good or bad physicians, it's whether they are seeing one or not, all right? Because the minute I ask them that and they stutter and they have to think, you have a chronic disease, surely you should know who your doctor is. And the minute they start thinking, or where do you go? And then they start talking about, I monitor my sugar at home, I go to the nearby pharmacy, then already my antenna is up. And usually it's not very wrong. So that's my first check with the patient once they come in. Then we look at all the other things that we normally look at. Of course, longer duration of diabetes is a big risk factor, number one. And then greater hyperglycemia, i.e. poor control. And then that, of course, leads you to the next, which is your higher HbA1c. Although now I'm learning new things. I was so keyed into the previous presentations. It's amazing what's going on in the world of diabetes. And then, of course, your glycemic variability. As you saw in the previous example, all patients had a HbA1c of 5, but you could see how much variability each of those patients was having. So that is also important as a marker for risk for diabetic retinopathy. And then, of course, there's comorbidities. You know, that child who is usually so nice until his cousins come to visit, and together they become a riot. So that's how it is with diabetes. By itself, it can do some bad, but once you now have comorbidities in form of hypertension, nephropathy, dyslipidemias, smoking, higher BMIs, then you find that there's a higher risk for progression to diabetic retinopathy. And then now there's slightly newer biomarkers, not entirely new, but of course there's C-reactive protein, because we are finding there's a huge inflammatory component to the progression of diabetic retinopathy, hence the use of some of the newer drugs like faricimab and also some steroids like dexamethasone. And then, of course, increased serum homocysteine. When you look at the eye of a patient with elevated homocysteine, it's like a 40-year-old with an 80-year-old eye. Arteriosclerosis, and you imagine that this patient is much older just by looking at the eyes. And of course, advanced glycation end products. There's other biomarkers that we look at in the eye, and one of the most important one right now is vascular endothelial growth factor and platelet-derived growth factor, especially the first one, because in patients with ischemia in the retina, you find the eye sends out an SOS asking for more blood in the form of vascular endothelial growth factor, which unfortunately in high amounts now causes abnormal retinal vascular proliferation, leakage of blood vessels, leading to proliferative retinopathy and macular edema. And so a lot of the drugs that we are now using in the management of diabetic retinopathy, diabetic macular edema, are anti-VEGF or antiplatelet-derived growth factors. And those are quite common now in practice. And then, of course, reduction in anti-angiogenic factors. And then finally, when we look in the eye, there's patients who have lots and lots of microaneurysms. Those are usually poor kind of indicators because they cause leakage, change in retinal vascular diameters, and retinal neurodegeneration. So those are some of the biomarkers we get. So now let's look at these eyes where the diabetic retinopathy is happening. So you can see there, we have your normal retina, and next to it, you've got an eye with diabetic retinopathy. Look how beautiful that first picture is. Huh? Optic nerve there, macula, beautiful blood supply, and the chaos that ensues when you have diabetes that is poorly managed. So, of course, when we talk about the retinopathy, we must think of at least 4 distinct entities, and I'll just speak to them very briefly so that you have an idea that you're not just looking for these hemorrhages. So the first one, of course, is your traditional diabetic retinopathy, which goes from non-proliferative to proliferative. And this is in the terrible stage where you have new blood vessels forming around the optic disc and elsewhere, and these are extremely fragile and tend to bleed easily. And the danger is that this patient could still have 20/20 vision, but is on the verge of bleeding. All right? Next one, of course, is the diabetic macular edema, where you now have the raised VEGF, vascular endothelial growth factor, causing leakage at the macula, and you get a lot of fluid and exudates, which are cholesterol coming at the macula. This is what it looks like on OCT. And this is the macula where your sharpest vision is, what you used to read, what you used to appreciate color maximally, and now you're starting to getting damage and edema. And therefore, vision suffers, and they'll often complain of poor vision, especially reading vision. And then, of course, now the ischemic maculopathy, where the blood vessels are damaged. And you can see here now, when you look at the angiograph, fluorescein angiograph, there's loss of capillary network. And this now is an ischemic phase with poor response to treatment and poor visual prognosis. Now, the thing is that all these things can happen separately or together. So you can get a patient with macular edema and macular ischemia occurring at the same time. And it's important to know that so that you manage them appropriately and prognosticate appropriately so that your patient is well aware of what they hope to get at the end of it. Now, when things go haywire and nothing is done, even at this point, then you go to advanced diabetic eye disease. Now, these are, blinding conditions because now you go into the stage of proliferative retinopathy with vitreous hemorrhage, with tractional retinal detachment, or even neovascular glaucoma. These are all very terrible complications of diabetes that are so difficult to manage, and they are expensive to manage with pretty poor outcomes. Okay, so that is the retinopathy, and you can see it's a wide range from proliferative to macular edema to ischemia to advanced diabetic eye disease. So these patients are coming to you now as the physicians. So it is up to the physician now to direct the patient to the right place to get an earlier diagnosis. Now, we found that about 19.2% of our patients have some form of diabetic retinopathy at diagnosis. These are Western studies. It must be worse in our setup. The studies we've done show between 16 and 35%, depending on where the study was done. So it's quite high at diagnosis. Now remember, in med school, you are told for your diabetic, by year 5, send for an eye review. Now, 20% of your patients will not benefit from a review for diabetic retinopathy that was there when they were diagnosed. So that doesn't hold anymore because you're finding up to about 20% have some form of retinopathy at the time of diagnosis of their diabetes. So if you stick to, now for type 1 diabetics, it's a bit different because they develop their diabetic retinopathy a bit later. So for the type 1 diabetics, some people, the International Council of Ophthalmology, the American Diabetes Association, will often advise that you can send them for their first eye checkup after 5 years of diagnosis. But I feel, and some other studies concur, that 3 to 5 years may be safer. I have seen patients who come for their first review as type 1 diabetics, and they are at proliferative stage. And proliferative diabetic retinopathy is so much worse in type 1s, because for adults, the vitreous is liquefied, separated from the retina often. This one, the vitreous is thick and stuck to the retina. So these new vessels have an amazing scaffold to grow on into the eye. So you find this huge mushroom of vessels at the optic disc that is just so difficult to operate on. Now, the next thing is that once you refer at diagnosis, the next thing is, what is your frequency? Of course, that will depend on the severity of the disease, but worst case scenario, if you tell your patients, go see an eye doctor at least once a year, you're in good books, because we have certain conditions like diabetic retinopathy, as I mentioned, proliferative retinopathy. This patient could be at 6/6 today and wake up tomorrow not seeing a thing because it bled overnight. So at least get that annual review so that for the asymptomatic presentations of the disease, we are able to see and treat in good time, all right? Now, you can also choose to refer upon presentation of symptoms, which is what I remember we did as interns. We used to run the clinic in Nyeri where I did my internship, and you'd have like a pile of 50 cards by yourself, and we never thought of the eyes until the patient mentioned it, which is dangerous, because then you're referring at the point of presentation of symptoms. And we know that if you refer at the early stages of the disease, you can retain or even gain vision. But when it comes at the later stages, we're talking tractional detachment and all, if you're lucky, you maintain that poor vision. You might have minimal improvement in certain cases. If it's a plain vitreous hemorrhage, you get pretty good outcomes. But otherwise, some of them, you actually just get a continued deterioration of vision no matter what you do because of backlog of complications to the nerves and all. And then, of course, you have significant morbidity, and it's more expensive to treat. A laser procedure is about 10,000 where I work. If you do a vitrectomy for a diabetic, because of the complexity, costs about 200,000 shillings. Now, you can see that difference. 10,000 versus 200,000. It's a huge difference. And you can actually and the benefits, of course, and the outcomes are much better for that earlier stage of treatment. So that's what we are trying to get, more patients coming in early. So when the patients self-present, this is what they are coming with. Now you can see those same new vessels are there. It's only now that they have bled. And now this patient will tell you, sioni kutoka juzi. For them, this happened yesterday or last night or 2 days ago. But we know it's been brewing for so many years, and at any point you could have caught it. So blindness from diabetic retinopathy in this day and age is really not a thing we should be dealing with, but unfortunately, we deal with so much of it. We run a retina clinic at CTI. We see about maybe 35 to 50 patients with diabetic retinopathy every day, Monday to Friday. And I mean, that's just one center. I know they're doing the same at Lions and many other places. So this patient tells you, I lost vision 2 days ago, but you know this thing has been brewing and we could have avoided it. The other ones will tell you, naona moshi. Now those are the worst kind. By the time you see smoke, things are bad. The patient tells you either it's, now you're going to the levels of neuropathy or tractional retinal detachments. It's becoming more complicated to deal with. It's better to deal with floaters, naona marudurudu. They'll describe all sorts of things. Better that than the patient who tells you, I am seeing smoke. It's terrible. Often there's not much you will do to help that patient because the nerves are going, there's chronic ischemia of the retina. Not much is going to help this patient. So treatment, luckily, I wouldn't be here talking to you about managing these patients and an ophthalmologist for an eye checkup. So, of course, he came with proliferative diabetic retinopathy and vitreous hemorrhage with his first visit to an ophthalmologist. So you can see this gentleman was not referred. And the bigger problem is that 3/4 of people with diabetes are in our setup. We have limited resources and we have the brunt of the problem. And 3/4 of these guys are supposed to be at work. This 54-year-old gentleman is supposed to be playing on his corporate ladder, not coming to the clinic, doing lasers, because once you come with eyes at that level, it takes about a year to settle that eye. By the time you do lasers, surgery, injections, cataract surgery, which often follows, it takes about a year to settle that patient down. Now you can do that math when it comes to loss of income and economic capabilities. So we are not the only one dealing with this problem. A big study was done recently called the Barometer Study, and it's interesting. You can get it online, where a group of people thought, what is happening with this diabetes? And this was a huge study that looked at patients, doctors, caregivers, relatives, everyone. And at the end, they were as confounded as us. But encouraging thing is that the healthcare professional was still the most trusted source of information. That is us. And that a lot of patients are still struggling with the management of diabetes, and very few were still enrolled in programs. You know, patient, you ask, where are you going to clinic? Starters. And then awareness luckily has gone up, and the patients are concerned. I've done a previous presentation on, are patients concerned about losing blindness? And blindness is the most feared disability of all by far, more than quadriplegia and deafness, even madness. It is the most feared disability. But patients just think about it and they do nothing. And that is a challenge. And that's what this was trying to get to it. So there's maybe a lack of appreciation of the urgency, limited access to patient education. And we also found in this particular study that 25% of physicians, that's this entire side, that's a quarter, had never referred a patient for an eye checkup. Now, when I come next year, please invite me. Let's say that that has moved to here. Then only half of you will say you never referred to an eye checkup. I'd rather if it was all the way over there. And of course, there were no clear guidelines from the ophthalmologist either. So we are not, we are not innocent either. So those are just some of the thoughts I wanted to share with you on diabetic retinopathy, and just urge you to remember to refer your patients in a timely fashion for most effective treatments and outcomes. Thank you.
Now you understand why we keep bringing him, Now you understand why we keep bringing him every year, right? But my first question to you, Daktari, in as much as, how many are you ophthalmologists in the country?
Close to 200.
Ah, excellent, 200. So do you think that's enough for Kenya?
Not nearly as much.
So what I want to know is it called Ophthalmology Society of Kenya? What are you doing in terms of educating physicians about, is there a role for this ocular camera so that we can do it while in our offices and then refer? It feels like there are not enough of you and we're not too sure what we can be able to do. As I invite our panelists who want to replace us, AI specialist Dr. Rilwan, Prof. Nancy, who has talked about GLP-1, I feel like I should be using it, and Dr. Gaman. This is really exciting, don't you think, when we can predict how long we will take to actually have this Q&A session. I would encourage, if you have any questions, please write them down and bring them to the front as we ask the panelists some questions. So the first question is towards you. You'll answer that. And then I want you, Rilwan, to be thinking about this. The blood glucose meters use and extract glucose electrons from a blood droplet to provide these results. So how is this non-invasive product actually going to provide accurate results for our patients? How sure are we that it can be able to predict accurately compared to what we've been using? We'll start with Dr. Mushai in terms of educating us physicians. Can I be honest? I get these fancy readings. Have you received that? You get these fancy wavy lines, and then you people love abbreviations like CME, DCME, LME. Sometimes I'm just like, yeah, the patient is showing me I have no clue what to do. So what are you doing towards education?
Excellent. We are guilty as charged. So I think in terms of diabetic retinopathy screening, we are doing a lot currently, because now we have set up a number of screening programs that are camera-based and soon moving to AI-based. I'll give you the first example was Kenyatta Hospital. We used to do screening, and we used to screen 10 patients per week, 40 in a month, therefore. And that's what we knew was screening. Until the day I met with Dr. Ngare, and he told me he's seeing about 250 new patients. So we realized there was a huge gap. And that's when we moved to camera-based, and the first pilot was at Kenyatta, and we were able to increase our screening to actually 300 per month. So we caught up. So we realized there's no other way. And so the current prescribed way of screening is camera-based screening in the medical clinic, not the 10 patients who came up to the eye clinic. So that is how screening now must be done. So our outreach programs are now focused on camera-based screening, now swiftly moving to AI-based, where the patient can get an interpreted result and a recommendation on site without having to wait for an ophthalmologist's response. None. For screening, we normally do not actually charge. Yes. Well, cameras will range from the lower tier camera will cost maybe about, how much is that? Came to about $9,000. Yeah, about $9,000 for a camera with AI capacity. That's probably the cheapest. So, and I know a lot of the eye people would actually be willing to place it in a medical center at no cost to the eye center just to get the right referrals. Yeah.
I hope ministries listen. Sure. Dr. Rilwan?
Rosie, probably if you were listening to my talk, you would have not asked that question, but I think I
understood. I understood,
okay.
But someone didn't.
Okay, so basically, just to finish up what Dr. Mushai was saying, their cameras, they're those bulky cameras that are there, but now I think they're those cameras for the iPhone users. They're those ones, I don't know if it's with Android now, but they're those ones you attach on the iPhone.
Oppo has.
Okay. They're those ones you attach on your iPhone, and they are AI based. You just put in the patient's eye and it will predict for you that this patient possibly has retinopathy or no retinopathy. So that one is just in your pocket and you can actually carry it. So sorry, I don't have the price, but there are those ones available now. To my question regarding the non-invasive blood glucose monitoring, I think Dr. Gaman, Professor Kunyiha had put a disclaimer that what we were discussing was mostly in terms of experimental in some cases. The non-invasive has not been approved or yet in terms of a way of monitoring blood glucose. I think there was a watch that was out that was purporting to do that, but there was no FDA approval for that. So probably it's not something probably we should be discussing, but we're discussing it because of possibilities of what's going to happen in the future as we're discussing AI, what is happening now currently and what is to be expected as we move forward.
Spectrophotometry. Light waves. By the way, what's being sold on the internet is all crap. Okay. Please don't buy those watches. Yeah.
So good. So thank you all the speakers for those excellent presentations, and welcome Dr. Mushai once again, my good friend. So he actually writes down. We have many referrals between us, and he actually writes down the diagnosis. So at least I don't have any issues struggling with those. So thanks a lot. So first question, this to Professor Kunyiha. What's your comment on pioglitazone on strokes and diabetes? How do we introduce this for our patients? So pioglitazone and strokes.
I think pioglitazone, remember there was a lot of controversy initially with Avandia, and then they removed them because of the fluid retention and heart failure risk. Now we are thinking more about instituting them for insulin resistance and early on. So they're not potent HbA1c glucose lowering. You're using them for the other effects, so not for the HbA1c reduction. So what happened in the guideline is they are shifting back to their use when they had kind of been sidelined as an insulin promoter, improving insulin resistance and the effect on endothelial dysfunction.
So last question is to Dr.
And
Mushai.
fatty liver, which we talked about here.
Yeah, so I'll just combine these three questions in one. So it's basically about screening. So people asking what is available there for screening in terms of AI, and are there any screening apps available? Then probably there are patients who come, for example, with pre-diabetes and yet have diabetic macular edema. What should you think about in that case?
Okay, in terms of screening, as you mentioned, there's the traditional bulky camera and now a lot of handheld devices, and those are widely available. So the screening is available in terms of cameras are there, eye clinics are there, and we've placed, even some companies like Novartis had placed a roving camera that went to a couple of clinics. So that is available. When it comes to AI, a lot of the tools had been kind of validated for Caucasian eyes. So there's a study going on from Rwanda But actually the study subjects had initially been taken from Kenya, Nakuru by Professor Shiko Madenge, and now they're validating the AI system for African eyes, because it's slightly different, because it basically looks at now presence of exudates, microaneurysms and all that to kind of make a diagnosis and a recommendation. So that is actually ongoing. There's a guy from Nigeria, Stephen Odaibo, who has a system that has been approved by the FDA in the US for screening. So now the tools are now available. It's just for us actually to adopt them. So the cameras we are buying currently, like at CTI, have now AI capacity. So usually it's a module you can add. So you buy it making sure you have that module, because that's where it's going. So at least that is happening actively. Second question was about?
So pre-diabetes, but
Yes.
very advanced eye disease. What do you
Yes,
think
yes,
about
yes.
in that setting?
I think as you're saying, pre-diabetes, I mean, you'll have your definitions of what you're measuring in terms of sugar, but now the effect on the vascular system will be based on the pre-diabetes itself and possibly other underlying comorbidities. So we find patients with quite severe macular edema and it's not even apparent. You'll see it on those funny squiggly lines of ours on OCT. So some of them, even when we look, we don't see it. It's not obvious because it doesn't have your typical features of diabetic retinopathy. Not much in terms of aneurysms or exudates, but the edema is there. There's also an element of cystoid macular edema from query cause. Patients of macular edema from previous cataract surgery, ocular inflammation from other diseases, and other, where we do not know what is causing it. So I think that those are subclasses of patients you'll see with macular edema in a pre-diabetic setting with other comorbidities and without even other comorbidities. Yeah.
So I think that's all the time we have for questions. If you want to ask them some more questions, you'll find them over tea time. But the challenge to the ophthalmologist is, hey, trainer, some of these things, I can tell you the little knowledge that I had about using a fundoscopy. How many feel confident enough to use a fundoscopy? Hey, 2 out of 3. Eric, you've lied. Maybe there's a 4th one at the back.
So good. So we'll quickly shift gears, and now we'll move on to our next talk. And it's given none other by Dr. Rosalind Ngugi, who I'm sure you've all seen, the backbone of this particular conference in terms of organizing and making sure everything runs smoothly. So she's a consultant physician and endocrinologist, and she's our vice president, Kenya Diabetes Study Group, and the current Nairobi chapter KAP chair. And she's based at KUTRH and also a lecturer. So she's going to now give us a talk with regard to the diabetes puzzle, piecing together the best care for patients with type 2 diabetes and Savia. So thank you so much, Dr. Rosalind, and we'll give you the floor. So give a big round of applause, then we'll kick off. Thank you.
Thank you. I know it's been an exciting morning, but let me bring you back down to reality. Yeah? Reality is it's a low resource setting, so let's make life more practical. And why did we think of putting it as a puzzle? Because we are faced with so many things that we have to think about when we are managing patients with diabetes. You have to think lifestyle, nutrition, what support are we giving, what's the right treatment, do we have to worry about adverse effects? So I'm going to try and piece this all together and teach you how we are going to figure this out together. So these are my disclosures. It's been sponsored by Xavier. So let me take you through the art. You know there's a science behind it, but now I'm going to teach you the art of actually managing patients with diabetes. So we'll start with what are the consequences of an unsolved puzzle. Now people with type 2 diabetes have found to have a 2-fold higher risk of cardiovascular disease versus people without diabetes, and you can be able to see the graph there. And what we found going forward is for every 1% higher HbA1c, you have an 18% greater risk of myocardial infarction. So this is what is actually killing these patients. And you can see it's both in men and in women. What they found surprisingly is if you had poor glycemic control in the first year, it actually increased the risk of micro and macrovascular deaths. Before it used to be, we start one drug, move on to the second one, and then the third one subsequently over 3 months. But what we are saying is this is actually contributing to mortality, and we need to hit fast and hard. Now, what are the systemic consequences of this microvascular disease? You've seen it causes a microangiopathy. In the eye, you'll get your retinopathy resultant blindness. In the kidney, we talked about it yesterday, end-stage renal disease. For the nerves, Fabian talked so much about the foot ulcer, and you know this can actually cause also sudden death because of the autonomic neuropathy. For the heart, angina and heart failure. Brain dementia. For the vessels, you have high blood pressure. The bone marrow, you actually have impaired vascular healing. So we really need to control the hyperglycemia. Now, when they looked at a couple of adults in the US and looked at the prevalence of both the micro and macrovascular complications in type 2 diabetes, it was quite high, spanning across diabetic eye disease, kidney disease, heart disease, and so there's actually a problem. So let's unlock this puzzle. When we are faced with this patient who has type 2 diabetes, what are we going to do? One of the most important factors we found, and at the end of the day, is glycemic control. Control the sugars, you'll be able to control your complications. And they found that glycemic control was actually the most important factor in reducing what's killing most of our patients, stroke and myocardial infarction. And this we learned from as far back as UKPDS. With every 1% reduction in your HbA1c, you had a 37% reduction in your microvascular disease, 43% reduction in your amputations because of PAD, 21% reduction in your type 2 diabetes-related deaths, 14% reduction in acute myocardial infarction, and 12% reduction in your stroke. So we really need to actually control this glycemia. So let me try and make you puzzle masters. So we have to have a target, right? We want to finish this puzzle. We want to sort out this patient, right? So set a target. And the targets have already been set, and the consensus was, according to AD and ESD, we target less than 7%. For those who are younger, no complications, then we can be a bit more strict. And so they said when you're looking at a patient and you want to focus on treatment, they may have comorbids. Focus on the blood pressure, target less than 130/80. Your HbA1c target, less than 7%. For the elderly, be less strict, maybe perhaps 8%. And for the younger ones with no comorbids, if you're targeting remission, less than 6.5%. You can see your LDL targets, and if someone already has had a stroke or an MI, then you consider antiplatelet agents. And this forms the basis that, one, we want to do individualized care. The patient is at the center of the circle, right? But you can notice, even as they've added things like cardiorenal protection, glycemic management is still very key, because this is helping in reducing your microvascular complications. Then there was the concept of weight and glycemic management, and anyone with cardiovascular risk factors or already has advanced cardiac disease, then you consider that. And this has formed the basis for these guidelines, right? That you risk stratify your patient. If you have cardiac disease and you have kidney disease, then you look at SGLT2 and GLP-1 analogs. If you're thinking weight, if you're thinking hypoglycemia, if you're thinking cost, then we need to manage this patient. So let me show you what we are going to do. Number one, look at patient preference. I don't want to take so many drugs, or which is going to be the one that I prefer. Number two, balance benefits and potential harms of this treatment. Look at the risk of both micro and macrovascular complications, and that is as you're stratifying them based on age, duration of the diabetes, and the complications. Do they have any comorbids? If they had hypoglycemia, what are the risks associated? Will this patient benefit from self-monitoring and the intensity, and then of course access and cost? And that's what we're going to go. So let's build this puzzle together. Let's talk efficacy. I mean, at the end of the day, if you're going to give a drug, you have to be sure that it's actually working, right? So which are the agents that we found to be efficacious in lowering your HbA1c? Most efficacious are things like your metformin. Please allow me to call them TZDs because I am Kikuyu. Sulfonylureas and your GLP-1 analogs. The ones that are not so efficient, of course, is your SGLT2 inhibitors, just as well the cardiologists and the nephrologists like them because of their pleiotropic effects. And then your DPP4 and your alpha-glucosidase inhibitors. The alpha-glucosidase, we don't really use them. And what we found in the meta-analysis is that when we looked at all these drugs, they were efficacious. They do work. But do they all work the same way? Perhaps not. So when they looked at meta-analysis of 75 randomized controlled trials, they found that the most efficacious was your sulfonylureas. We keep throwing them out, but honestly, they're actually quite effective. Then you had your biguanides, that's your metformin at -1. And then you have the other agents like your DPP4 and your SGLT2. So not all drugs work the same way. Then we go ahead and we said, what if we actually compared some of these drugs? So one of the drugs that, one of the studies they actually conducted in the UK was a cohort of about 1,986 patients. And some were given sitagliptin versus gliclazide. And then they were followed up. And what they found was, if you targeted a HbA1c of less than 7%, gliclazide was actually able to achieve that target by more than 35% earlier than your DPP4s. And if you even targeted a low HbA1c of 6.5, you're able to achieve it better with the sulfonylurea gliclazide compared to your DPP4, which was your sitagliptin. So, you know it's efficacious, but is it tolerable? Maybe let's see whether these drugs are actually we are going to be able to balance efficacy with tolerability. So if you already have a diabetic patient who's obese, you have to think, am I going to give drugs like your TZDs and your sulfonylureas which show weight gain? Or am I going to give neutral agents like metformin and your DPP4 inhibitors? Or the ones actually that have been associated with weight loss, which we've been talking about consistently, GLP-1 analogs or your SGLT2 inhibitors. Now what we found was, you can see your GLP-1s and your SGLT2 inhibitors actually are associated with weight loss, which is good. But the problem we had was with the sulfonylureas, there's an associated weight gain, which is more of a defense mechanism if you have hypoglycemia or predicts that you're likely to get. You're so afraid of the hypoglycemia, you end up eating even more. And so the question is weight loss really clinically relevant for our patients with type 2 diabetes? And the ADA ESD 2022 consensus statement said was that weight reduction was actually seen as a strategy to improve your glycemic management and to reduce your risk related to your weight. And they found that if you had a weight loss of about 5 to 15% as your primary target, it was actually going to improve your glycemia. And even higher, up to 10 to 15%, was associated with remission. So for those who you want to actually target remission, you have to think, individualize this patient, and let's talk at the day one. Are we targeting remission? Are you focused? Are you motivated? Then you can. But remember, if I'm going to give drugs, I have to weigh what is the one thing most patients are afraid of? Hypoglycemia. So most of the drugs that we have, metformin, your TZDs, your GLP-1s, DPP4, and SGLT2, have been found to have a lower risk of hypoglycemia, unlike the sulfonylureas. So I've told you, sulfonylureas are very good in lowering your HbA1c. And the problem is it causes hypoglycemia, which our patients are most afraid of. So when they looked at a meta-analysis of the drugs that are likely to cause hypoglycemia, they found things like your metformin, your DPP4, SGLT2, and even your GLP-1s are actually good in terms of they don't have such a high hypoglycemic risk. But look down at the table where you can see blue. For the men, it's the lower bars. And you'll find that the SUs, there's a significant intra-class difference. Eric, that's for you, the color that you're wearing. And you'll find that in as much as they all cause hypoglycemia, there's a significant intra-class difference. That if you try and compare, say, glibenclamide to gliclazide or to glimepiride, there's actually a difference. So even as we say they're all bad, they aren't. You have to choose a specific sulfonylurea. So let's balance this. We've talked efficacy, we've talked tolerability, but then we have patients who already have advanced cardiovascular disease. So we say, why don't we give them the drugs that we know have been shown to be quite efficacious? And these are your GLP-1 and your SGLT2 inhibitors. However, remember that FDA a couple of years ago had said that, for you to be able to introduce a drug, you need to have come up with a cardiovascular outcome trial. But do all these patients, should they belong in these studies? I mean, majority of our patients actually may not be having advanced cardiac disease or renal disease. And when they looked at a population of about 23 million, we found actually 51% of these patients actually were not eligible for enrollment, and these are patients with type 2 diabetes. Look at the other cardiovascular trials, like for the SGLT2 inhibitors, like the EMPA-REG, your Canvas, or Declare-TIMI. The ones that are in orange or red are patients who actually were not eligible for enrollment. When you look at them combined, there actually is quite a big enough number to say, you know what, not everyone at the onset will require these newer agents. You see, the thing is, whenever you go to a shop, you want what is new, right? So you throw off the old and continue with the new. But the old still looked good, so why are you throwing it out with the rest of the clothes? So something to think about. The majority of our patients do not actually have cardiovascular disease. Look at all these trials for the GLP-1 analogs, the ones that we talked about the whole conference. Not everyone should be prescribed this, because you can see only 15%, and you look at 13% in your leader trial, 12% in your sustain. These are the people who met the eligibility criteria. So there's still a large proportion of patients who are not actually being included in these trials. You understand? So all these trials look at the patients who are very high risk, the ones who are prone to death. But what about these patients who are going to live for 30, 40 years? Are we actually randomizing them? And you'll see, in terms of applicability of these outcome trials, only 31% will benefit. What about the others? So there's still a role for the rest of the other drugs, not so fancy ones, and we'll talk about in terms of the cost. So when we look at the limitations of the current structures for your CVOTs, it's including subjects who are only at high risk of a cardiovascular event. And then none of them are assessing outcomes more than 5 years. We want 20 years, 30 years, like the way the UK PDS and even the Steno 2 was showing us. And trials of less than 5 years are unlikely to detect the risks related to all these new drugs. So what we are saying is, they're not bad, but be careful about when you prescribe the long-term effects, similar to how we advise people on the COVID vaccine, and then now we are starting to see the effects. It's just something to think about. Look at the kidney. When we talk about type 2 diabetes and the kidney, the things they say is, one, lifestyle therapy, physical activity. Then they say first line, of course, should be metformin. Stop it when your GFR is less than 30. Then, of course, give SGLT2. They give them like sweets, I can tell you that. I find most of my patients already have them when they have come through the nephrologist. But how efficacious are they in terms of managing the glycemia? You still need to manage your glycemia, right? And that is why there's still a role of adding all these other drugs. But remember, in CKD, you actually have to consider the renal dosing. And that's why they say, other than the hyperglycemia, management of your hypertension, your salt restriction, your nutrition, and your diet. So there's still a role for all these other medications. So we know in kidney disease, I don't even need to, I think you've seen this slide 4 or 5 times in the past few days, that SGLT2 inhibitors have been shown that they actually have a relative risk reduction with regards to progression of your diabetic kidney disease, similar to the GLP-1 analogs, right? But, and even with the DPP-4 inhibitors, they found they were not retarding progression, that they can still be used, but at the end of the day, I'm going to extend, but at the end of the day, the issue was you needed to renal dose, except the newer ones like your linagliptin and your teneligliptin. But I'll take you back. Do you remember the advanced study where they combined drugs, including metformin and sulfonylureas like gliclazide, just to be able to stratify them between an intensive arm and a conventional arm? And what they found was, actually it was associated with a reduction in your major microvascular events, new or worsening nephropathy and retinopathy, and was actually found to be quite useful. So don't throw out our sulfonylureas in our CKD patients. There's still hope. Then, remember I'm teaching you the art. So let's talk price. These are patients who have other comorbids, right? So what are the cost implications of this? Your fancy GLP-1s that we've been talking about, how many can actually afford? Your SGLT2, thank God, because now quite a number of the pharma are taking them up. But our good old drugs like metformin and your TZDs and your sulfonylureas and now the DPP-4s are affordable. So again, do not throw them out just because they are old. Old is gold, I insist. Then I wanted to highlight actually one of the studies when they were looking at the use of dulaglutide, the GLP-1, to reduce the risk of MIS. Here I want you to focus on the cost. While it achieved its objective, 7 million rand is equivalent to 48 million Kenyan shillings. Meaning for you to reduce that one major adverse cardiovascular event in one person, 48 million shillings. How many have that in their account? We can be best friends right now. No? Okay. So just think about it. So let's piece this together. We've talked efficacy, we've talked tolerability, right? And then we've talked about the hypoglycemic risk, and we've talked about cost. So let's all bring this together. And the 4 pillars of diabetes management is 1, glycemic management. Don't throw it out. Number 2 is blood pressure, then lipid management, and then look at agents with cardiovascular and kidney benefit. Now the STENO2 was a study which had a mean age of about 54 years, patients who had a duration of diabetes of about 6 years, and they followed up these patients initially for the first 5 years. What they found was there was a relative risk reduction when you targeted all of these factors that we are talking about. And you can see it was from as low as 47% to as high as 60% reduction in things like all-cause mortality, CV death, and all. And when you compared it and followed up these patients for another 10 years, a patient was actually able to gain 8 years of their life simply because when you hit hard. Don't go gentle. It's the same way when you go after the woman you want to marry. You'll not be like, oh, we'll take 6 months. No, go after and state your intentions today. So it's the same concept. When we talk about a patient-centered approach to treatment, I will not treat Dr. Ngugi the same way, who's the oldest in the room. Maybe perhaps I shouldn't say that. Prof. CF, thank you for raising your hand. I will not treat us the same way. So you'll have to go easy if you know the patient has comorbids, isn't it? They have a shorter lifespan. I'm not saying you have a short lifespan, but I'm just saying take into account the patient, because not one size fits all with regards to management of your diabetes. So let me give you an example of how you would manage a patient. For the ladies, don't smile too much, you won't find him. So this is Mbogwa. He's aged 44 years. He's married, apologies, with 2 children. He has a clerical job and he's lived in Muranga for the past 3 years. Okay? He has type 2 diabetes for the last 4 years, no established atherosclerotic cardiovascular disease, and he has normal renal function. Current HbA1c, 8%. His LDL, not too bad, 1.8. BP of 125/79 with a BMI of 28. He takes metformin 1 gram twice daily, maximum dose, and is also on an ACE inhibitor calcium channel blocker for his hypertension, and is on a statin. So the question is, what would be your desired target for Mbogwa? I've put it back here so that you can see. What is your desired target? I said it at the very beginning. Okay, just raise your hand if you think you'd know what it would be. Of course, 7%. Even lower. I mean, he's only had diabetes for 4 years, right? So what agent would you then want to add to metformin to optimize his glycemic control? He's only 44, he has 2 children, desires more from the same wife, and at the end of the day, you want to make sure he lives up to 100. Then what would you give? He's a clerk. Would you give him a GLP? He can't afford. SGLT2 inhibitor has no cardiovascular risk factors. Would you give him a sulfonylurea? Yes, he's a clerk, isn't he? He can afford and he'll achieve its objective. Can still give a DPP-4, but insulin, there's no Mbogo will agree to that. And finally, you have patients like Rowena, 45-year-old, she's employed as an accountant, she's had type 2 diabetes for 4 years, she has no comorbids, no long-term complications, BMI is perfect, what I desire, 25. Then her current medications are metformin, a gram BD, and she's also on gliclazide MR at 120 milligrams once daily. She would like to fast. So what would you advise her? Don't fast because of risk of hypoglycemia. The reason I put this was because we had a whole session on diabetes and Ramadan that was conducted by our able team, Dr. Gaman, Dr. Saira, and Dr. Rilwan, and the rest of the Kdsg. So I hope you actually followed even online. Would you discontinue the sulfonylurea because you're worried about hypoglycemia? Continue on her current regimen, or can she fast but she'll take the sulfonylurea when she breaks her fast? Eric, it's because you have the mic.
You can do D, which is then having a significant risk of hypoglycemia, no comorbidities. So you can ask her to take it when she's breaking her fast.
Excellent. So if it's metformin, you don't need to change the dose. And I mean, we've even got the guidelines. Part of our guidelines actually is with regards to Ramadan, that you don't need to do dose adjustment when it comes to metformin. And then for your sulfonylurea, if it's once daily, it's when they're breaking the fast, because that's when they're likely to take bigger meal, I guess. And then twice daily, of course, you will ensure that your dose for iftar when you break your fast is the same, but you try and reduce the dose when you're starting your fast. For the older drugs, of course, like glibenclamide, it's not advocated. Which are the drugs that don't need dose adjustment? Your DPP-4s, your GLP-1s, your TZDs, and your SGLT2s. So, have I taught you the art of managing a patient with diabetes? Okay, then my job is done.
Yes, thank you for that excellent talk, Rosie, and for entertaining us, and you made us laugh quite a bit. So we'll take just one question from the audience. Maybe you could just raise your hand in the interest of time, then I'll come where you are. One question, going once, going twice. Well, excellent.
Thank you, Rosie. It's always an honor to listen to you, and it's entertaining, I agree. I love that you've given us the art of managing diabetes, but I have missed a key component in the art. How do you make patients adopt healthy lifestyle? Would you want to just say something about that as the key above everything else you've said? Thank you.
Excellent. That's an excellent point. You know, before you even start talking drugs, it's, of course, at the end of the day, what is key is lifestyle, your diet, your exercise. We had a session on nutrition and all these alternative therapies that patients are coming up with. One very key thing is that no matter how many drugs you end up giving the patient, if their diet is not good, then for sure you will not be able to achieve your targets. Similar with physical activity. No, the gastroenterologist has decided, okay, you want to talk about the gut and health. But the point is that you have to ensure from day one when you meet the patient that you talk about diet and exercise, and with each subsequent meeting that you have. I feel like we only send to the nutritionists or the dietitians the first time, right? And then we forget, and then you come back after 1 year and they're like, have you ever gone back to see them? No. And the problem is also us, because we say we are working together, but truly we aren't. My plea, I think, on behalf of the dietitians is, it's not a one-off. You actually have to walk this journey together such that you actually, and the good thing about the dietitians is they've also adopted the body fat composition, and they talk about the exercise. So it's a whole package in one. At every visit, if you can be able to package this in your various hospitals, it would be important that you, other than seeing you, I think they should actually pass through the dietitian before they come to you, just so that they are implementing what they've been taught.
Yes, thank you, Rosie, for your excellent talk. It's always good to remind myself about diabetes and the kidney and the others. So, yes, mine is about the issue of nutrition and weight. So, first of all, I'm surprised that such an eminent conference doesn't have a section for us to come in Because the truth is, people struggle with, at the end of the day, we can talk diet for forever and ever and exercise. But the truth is, many people are unable to achieve proper weight control based on those. And we do have the modalities for dropping weight quite impressively. And of course, as weight drops, adiposity reduces, and of course, you have less insulin resistance. I hope I've used the right terms, diabetically, if there's such a word. So, so yeah, next time, please have us come in and do a session on the GI management of weight loss. I think it's at the end of the day, we're going to have to head to a point where weight loss is going to become very, very key in your diabetes control. That's the truth of the matter. We have tried the issue of diet and exercise for decades and decades, and I don't know what your results are so far. So bring us in, and I think we can achieve this a bit faster.
Yeah, that's noted. Actually, when we've been talking so much about the GLP-1s and weight control, we're actually going to have the symposium, KP and Kdsg, where we'll have the surgeons, the gastroenterologists, and the endocrinologists talking about weight loss. And we're actually going to have even an obesity symposium in October, so watch out for this space. Now, in the interest of time, I'm going to close this and make a couple of announcements. Number one, if you could put up the QR code, for you to be able to receive your CPD points and your certificate, we are encouraging you to use the QR code. I'm not the QR code, I'm hoping they'll put up the QR code. There's going to be the QR code for the CPD and the certificates. There's also the poll survey we are conducting as Kdsg in concert with Gets Pharma with regards to your knowledge, attitude, and practices with regards to diabetes management. We keep complaining that we are not having certain standards, but we don't know the problems that you're experiencing, so this will go a long way towards improving that and influencing policy. You will get your tea right now at the exhibition stands, but because we are short on time, I'll encourage you to be back by 11:45.